or many masks. So all these have separate surgeries to be done, and accordingly, if the patient needs surgery, surgery can be done to treat the patient with snoring and sleep apnea. Laser is a wonderful machine by which most of the surgeries can be done for snoring and sleep apnea. We do have it in Peerless. The carbon dioxide is used mostly by the ENT head and neck surgeons. We do have it and use it. We want to see all of us to be happy, so eat healthy, exercise regularly. Laser is a wonderful machine by which most of the surgeries can be done for snoring and sleep apnea. We do have it in and if you come across sleep disorder patient, don't ignore. We do have it and use it. Killer. We want to see all of us to be happy, because the next eat healthy, exercise regularly. Laser is a wonderful machine by which most of the surgeries can be done for snoring and sleep apnea. And if you come during the learning phase, if a child do not ignore, we do have it and use it. Do not. We want to see all of us to be happy, because the next eat healthy, exercise regularly. Laser is a wonderful machine by which most of the surgeries can be done for snoring and if you come during the learning phase, if a child do not ignore, we do have it and use it. Do not. We want to see all giving this to be happy, because eat healthy, exercise regularly. Laser is a wonderful machine by which most of the surgeries can be done for snoring and if you come during the learning phase, if a child do not ignore, we do have it and use it. This is important. We want to see all the stations of the happy is a vital healthy exercise regularly. Laser is a wonderful machine by which by surgery can be done for and if you come during the learning phase, if a child do not ignore, we do have it and use it. This is important. We want to see all the stations of the happy is a vital healthy exercise regularly. Laser is a children by which by surgery can be done for unable to speak and if you come during the learning phase, if a child and inattentiveness due to decreased hearing. As mentioned previously, blocked nose leads to eustachian tube blockage, which results in decreased hearing. Blocked nose usually occurs due to a frequent cold-like symptom called rhinitis, and also very commonly in children due to enlarged adenoids. So adenoids and tonsils obstructing the airway is the single most commonest cause in children having snoring and sleep apnea. So it's a bit different from the adults. As the child continuously breathes through the mouth, he or she snores, his or her upper jaw moves forward, keeps mouth open, sticks tongue outside, which we call as adenoid faces, and this turns out to be a permanent fixture in that child. This is one of our patients from Durgapur only, long time back. We did the operation where you can see there huge adenoids with conductive deafness due to glue ear. So thus, if a child snores or is a mouth breather or has nasal obstruction or upper jaw becomes prominent or has difficulty hearing or complains of frequent pain in the ears, it must be realized that something is not right, and it's usually what we described earlier, either the adenoids or adenoid and tonsil together with or without glue ears. So with a little awareness from all of us and proper timely management, a child will again bloom up with a sweet, smiley little one we all want. This is my son actually, long time back, yes. Are we sleepy? We still have 9 minutes. I still have 9 minutes to torture you. Yeah? You are ready? Okay, done. Actually, target जिंदगी में सब जगह है. 30 मिनट का target लगा दिया है हमको. Anyway, the next few slides is not about today's topic. When I have got this podium in front of you esteemed gathering, and I do represent Peerless. Now, as at the very beginning I said, it's not only ENT, it's ENT head and neck surgery. Few slides making interesting slides actually of what actually ENT head and neck surgery is. This is a slide of a person. We all know about parathyroids. Yes, parathyroids are very small. Moong dal, musur dal ki tarah hoti hai ye sizes. But this parathyroid was more than 6 centimeter, going in the mediastinum up to the upper part of the arch of aorta, that area. And your calcium level was sky high. It was more than 3000 something. Yes, 3000 something in this patient. So we did the surgery to remove the parathyroid, and it went down all of a sudden. Because this is the beauty of parathyroid adenomas. You do the surgery, it becomes half within 20 minutes. This is how we gauge that whether we have taken the right adenoid or not, or adenoma or not, or there are other parathyroids which are also in adenomata state or not. This is a lady called Himalaya who had chondroid chondroma. Chondroid chordoma is one of the notochordal tumors, very rare, and also it has a high incidence of recurrence. We did it almost 5-6 years back endoscopically from the skull base, and she is doing well without any recurrence. This is an adult patient of tracheoesophageal fistula, iatrogenic. Adult iatrogenic tracheoesophageal fistula repair is very difficult. Children, it's fine. Adult is difficult. It's again 4-5 years back. Till now, we are seeing her every year, and she is doing well. We do head and neck, various types of cancer patient surgeries, all, whatever you say, head and neck, with lip splitting, mandibular splitting. This is a lady from one of the political leader's sister, actually from the northeastern state, and here she is doing very well. This is an interesting case where there was a schwannoma. You can see with the arrow on the facial nerve, having a facial nerve palsy. We did a surgery for that, and he is doing well. Again, another neck dissection with maxillary tumor excision. We do endoscopic dacrocystorhinostomy, DCR operation. Endoscopically we do a huge mass starting from the mastoid tip up to the superior mediastinum we have taken out. This is one of the pictures. Lung cancers we have taken out with neck dissections. This is that person only. And this is an interesting case of Murshidabad, 16-year-old child who fell down and hit his skull on the floor. There was fracture of the skull. The fractured line went up to the your vestibule and also the facial nerve. So the facial nerve got paralyzed, and we did a facial nerve decompression on the table. You can see the child now can close the eyes properly. So it got reverted. And again, this is a gentleman who is having a floor of the mouth cancer. Floor of the mouth cancer. And you know what's the most common cause of oral cancer? We all say pan para, gutka and all those things. But the most common is denture. It can be sharp dentures or it can be ill-fitted artificial dentures. That's the most common cause. The next is all the tobacco chewing or anything which you put in the mouth and keep it. And khaini is the worst because along with tobacco, it has a corrosive material, lime, chuna. It has a corrosive material there. But this gentleman had a newly fitted artificial denture. Unfortunately was ill-fitted, so continuous rubbing caused a big tumor. He came from Nainital. It was such a big tumor that after taking it out, there was a big hole there. So what we did was pectoralis major myocutaneous flap we have put in. So this, what you can see inside the mouth, the skin, that is actually from the chest. He is doing well. Massive thyroids we do, and this is again a tumor of the oral cavity invading the cheek, the skin, where we removed everything, and again ALT, that is anterolateral thigh flap, we have used to reconstruct it. We do cochlear implants regularly. I'm trained actually, I have a fellowship, I'm trained with cochlear implants. We do cochlear implants. That is again another chapter we'll do someday later. So these are one of a few of our patients which we did. And carotid body tumor, this was done maybe 5-6 months back. We do carotid body tumors, so head and neck we do most of the cases. We also run special clinics like vertigo clinic, cochlear implant clinic, voice and speech therapy clinic, snoring and sleep apnea clinic, on which we discussed today. We are confident in what we do. We at Peerless Hospital, Kolkata are proud of our department. With these words, I presume, yes, till 2.5 minutes are left, but I won't take any more time. Thank you. Thank you all. If you do have any questions, I am happy to answer. Thank you all. No questions?
Hello, Manoj. Can I ask a question?
Yes? No?
Yeah, no, it's okay. What happened, suppose a case of pediatrics OSA, we get many cases of pediatric OSA, so with huge tonsils and adenoids. After operating the tonsils and adenoid, do you recommend any other thing for them, CPAP or something like that? Suppose they don't get improved with case of pediatric OSA. What do you do?
Few things are there. In Indian, Asian and African scenarios, even pediatric patients are obese in most of the cases.
Yes, we have seen.
So obesity is one of the causes of sleep apnea even in pediatric age group.
Yes.
But the most common is adenotonsillar hypertrophy.
Yes.
So we need to gauge it. If it out, all of a sudden the OSA goes off.
Yeah.
If it doesn't, that we need to predict even before the surgery. Even many patients, they come with huge tonsils and adenoids having OSA who are obese. I tell their parents that with these things, definitely it will improve, but you need to curtail on the weight of the patient. So we do your weight charts and diet charts and everything, even for the pediatric age group. And rhinitis is there.
Yeah.
Now with everything coming up, the industrialization and whatever, the real estate boom and all those things, rhinitis is blooming, isn't it? So that also needs to be addressed if it is there.
Can I, sir?
Yes, please.
Yeah. I'm Dr. Asif, Dr. Manojan.
Hi.
Excellent presentation, and I think it's an expert's domain, no doubt about it. So what I need to understand is, like in adult population, the name of surgery for this airway, mostly in that area, I think it instills a lot of fear into the patient as well as people. I know not for the surgeons.
Yeah.
But how do we get over this? How the awareness has improved in terms of not taking as the last resort, taking surgical intervention as the first resort? Because normally you try with the sleep hygiene, you try with the dietary as well as the behavioral habit change, then comes your NIV support, and last is surgery. That's how people look at. How do you change this? Is there going to be a shift, or it's already there in your place, and how the awareness is going to get better?
Yeah, it's a very good question in this sort of a podium, because you all are the one, after these lectures, who will spread that yes, there is a scope of surgery to your patients. That's number one. So awareness comes from the doctors. That's the whole thing which I said. Even this concept was there. You are having a DNS. If we correct your DNS, then the OSA will be cured. It's not that. You need to understand what it is. And if we make the patients understand about what they are having, then yes, the patient comes for surgery. So these sort of podium where you are interacting with doctors of other discipline, if scientifically you make them understand this is the synapse, if they are also suffering from it. So in this way, any sort of awareness, it goes on, isn't it? So it's an awareness, it's the way how you speak to the patient, and it's the problem. Yes, when my hair was black, I used to have a bit of a problem, but nowadays I don't have any problem convincing the patient if genuinely they need surgery. Yes.
Sir,
Questions?
Sir, I'm Dr. Rajiv,
Yes, please.
Chief Consultant Medicine, Durgapur Steel Plant Hospital.
Hi, Rajiv. Yeah.
Sir, very excellent message to us from your beautiful lecture. Sir, we are working in industrial sectors, and the impact on productivity, absenteeism, and so on and so forth.
Absolutely.
Sir,
Hypertension. So, hypertension is something which is related to OSA. Chronic OSA, look at a person who is obese, or if you look at a person who is having hypertension, or if a person is having sleep disturbance while asking them questions, then definitely those are the patients who can be sent for screening. Screening is very easy. You can do a sleep study. Sleep study, you don't need to put the camera in or anything. That's a specialist domain. But you can do a sleep study. The sleep study will tell you whether the patient is having any OSA or not. And accordingly, it's not that all the patients, they need surgery. No. OSA patients, as I have said, conservative, a huge chunk of patient can be treated with conservative management. Only a small chunk really needs surgery. And if the patient doesn't want the surgery to be done, CPAP can, I won't say that it will completely cure, but CPAP will address to that OSA until and unless only one situation is there where CPAP fails, and that is where the epiglottis falls back. Because if you give or advise CPAP to that patient where the epiglottis falls back, then the air, whatever pressure the air is entering through the from the CPAP through that airway, it will close the epiglottis more with increased pressure. So that is the only scenario where you need really surgery. Others can be avoided if the patient doesn't want, with a CPAP machine also. But again, if the patient is having severe DNS, we suggest that before taking the CPAP, to get the nose corrected, because with the severity in the DNS, the pressure that is recommended from the CPAP machine is much more than with a corrected nose.
thank you, sir. Thank you, sir.
Thank you very much. I am relieved. Thanks a lot.
So now to felicitate Dr. Bhattacharya, I would request Dr. Rupa Goswami and Dr. Nivedita Roy, please. And now to felicitate the chairpersons, Dr. Rupa Goswami and Dr. Nivedita Roy, I would request Dr. R. Kumar sir. Dr. Kumar sir, please felicitate Dr. Rupa Goswami and Dr. Nivedita Roy for chairing this session. So after this informative session by our guest speakers, we move on to the debates. For each item of the debate, 15 minutes will be allocated, 4 minutes for, 4 minutes against, 2 minutes each for standing your points, and 3 minutes for the final discussions. So the first topic of debate today is newer advanced diagnostic end of era of clinical medicine. For this, I would request Dr. Uday Kumar Das from ISCO Banpur and Dr. Jitendra Sarangi, RINL Vizag, to please come to the podium. And chairing this session will be Dr. Rajanjan Kumar Sir, our CMO IC, and Dr. Vinita Singh, GMMS Tata Steel Limited.
Copy.
Good afternoon. So the rules of the debate are 4 minutes each for the speakers and 2 minutes each for the rebuttal. For the 3 minutes, we'll open for the audience if you have any interesting question. So 15 minutes, we'll finish. So if we can start with Dr. Uday Kumar Das. Yeah. Can we have a show of hands? Who thinks that, who's for the motion in the hall? Just to see how much the speakers can influence you. Who thinks, who believes the statement? Who's with Dr. Uday? Only one, two. So you have an easy job then.
Medicine has evolved purely from bedside symptom-based clinical practice to a technologically driven science. The advancement in the diagnostic tools, right from MRI to CT scan, PET scan, genetic diagnostics, point-of-care diagnostic, have not only revolutionized the medical practice approach to clinical practice, but it has also increased our reliance on these technologies significantly. And this has probably gave rise to an important debate called newer advanced diagnostics, are they leading to end of era of clinical medicines? Respected chairpersons, judges, and members of this August gathering, I extend a very good afternoon to all of you. I am Dr. Uday Kumar Das from Banpur Hospital, and I will be talking in favor of this debate. The advanced diagnostic technology, particularly AI-assisted diagnostic tools, genomic testing, macrofluidics, wearable monitoring devices, are facilitating a fundamental transition in clinical practices, rendering what is called, what we used to have from subjective and reactive, where we used to wait for the symptoms to appear and then react, to a more data-driven, proactive, and personalized approach, rendering the conventional hands-on clinical skills less pivotal as this technology assumes a more prominent central role. We will be talking about the few technological innovations, and one of them is artificial intelligence in diagnostics. It has capability of detecting very intricate diagnostic patterns within the complex data and providing very enhanced accuracy in diagnosis with precision and consistency. Moreover, it also decreases the margin of error in diagnosis. The margin of error is being considered as one of the 4th leading cause of death worldwide. Now we are talking about the few diagnostic tools, AI-assisted diagnostic tools, which are significantly reshaping the clinical approach in medical practitioners. Microsoft AI Diagnostic Orchestrators. This AI uses a panel of virtual agents to simulate a medical team's reasoning, and it has achieved 84.5% accuracy in diagnosing complex cases compared with 20% by a control group of doctors. Another tool is Google DeepMind Health. It has achieved 94.5% accuracy in diagnosing over 50 eye diseases from OCT scans, surpassing human capabilities. Another innovation is the wearable healthcare devices and continuous monitoring. It provides us taking the continuous health data of patient in real time from outside the traditional clinical setting, making the better evaluation of patient's status and management. It also empowers the patients to take control of their health and share the data directly with the healthcare providers for better management. Point of care testing has already taken momentum in the emergency setting in critical care and trauma settings. It provides faster diagnostic with reduced wait time and give us better option to management. Genomic medicines and precision diagnosis. The gene sequencing technology identifies genetic mutations linked to specific cancers and inherited disorders, enabling yearly proactive and targeted interventions. Pharmacogenomics is another tool which provides us tailored drug prescriptions based on individual's genetic profile to optimize efficacy and minimize adverse effect. Another AI tool, what is called the Tempus Next, it combines AI with genomic sequencing and clinical data to recommend personalized treatment plan for cancer patients. Telemedicine and remote diagnostics has evolved significantly since COVID-19 pandemic, enabling access to healthcare from remote locations and transforming how patients receive care, from virtual consultation, telemonitoring to mobile health apps. With permission, can I have a few minutes more? 2 minutes now.
Time is up.
Can we allow? 3D printing and medical diagnosis. 3D printing enables the creation of anatomical simulation with detailed models of organ, allowing healthcare providers to study disease progression and plan appropriate surgical interventions with precision. Nanotechnology is another boom in diagnostic fields, uses quantum dots and biosensor to improve diagnostic imaging and accuracy. Advanced biopsy technology like liquid biopsy and optical biopsies reduces patient discomfort with faster result and enhanced diagnostic accuracy again. Lab on a chip technology delivers a cost-effective diagnostic with quick turnaround of result in a portable and easily accessible format. Data security has become another concern, and the blockchain technology is becoming an integral component of the healthcare ecosystems, ensuring that sensitive diagnostic data is securely transmitted and accessed exclusively by the authorized persons. Now, all these diagnostic innovations with speed and efficacy, accuracy and consistency in diagnostics, having capability to recognize complex data pattern beyond human cognitive capacity and providing targeted individualized treatment protocols have fundamentally transformed the medical approach in clinical practices from being reactive to proactive. So I like to rest my speech with a quote from Dr. Jane Smith, a healthcare innovator, that integration of technology in healthcare is not just an option, it's a necessity. Thank you.
Okay. Thank you. Thank you.
Respected chairpersons and dear delegates, a very good afternoon to all of you. I am speaking against the motion of newer advanced diagnostics, whether it is the end of a clinical era. Before I start my presentation, I think I have got the first vote of Dr. Ravindranath when he presented in the morning that the newer diagnostics, being a pathologist, he has said the newer diagnostics are only going to augment. And therefore, my first comment on this is the newer diagnostics are only going to augment and not to automate, meaning thereby that it is going to provide the doctors with the advances that are there, specifically with the science, so that the diagnosis can be earlier and quicker, and the patient can be treated faster and not to replace the person. And therefore, during the course of my presentation, I will try to justify what I said by augmenting and not by automating. Now, as we know from our third year of science, medical school, when a patient comes with his, symptoms, and then we take the detailed history, we go for the clinical examination, find out differential diagnosis, and then a probable diagnosis, and then investigate, and then find out, establish the diagnosis and provide the treatment. We have traveled from the ancient modalities of treatment, which was there 400 years ago, to what in the modern ICUs nowadays, where we were diagnosing the patients by just examining the pulse, rather than what has come during the beginning of the 19th century, when Sir Inthoven said that the electrical impulses from the heart can be recorded in form of ECG by finding out that the heart is placed in the center of a triangle connecting the right hand, left hand and the left leg. Similarly, in the first, when Sir Röntgen described the X-rays, invented the X-rays, and then the first X-rays was done, they said that it is impermeable to some of the tissues. It was put to medical practice to find out the tissues which can be visualized without opening it up. Then came, Madame Curie during the First World War, when she, invented this auto rickshaw type of thing, where she took the X-ray machine to the battlefield to find out if a patient has got any bullet injury or not, and you can see that a bullet is lodged in the chest of the patient during the First World War. So, development of the science has improved in the medical field. Then came, Professor Ian Donald, who invented and found that ultrasonic waves can be captured when they go into the body and can be captured back by the machine. And then he was amazed to find the baby moving inside the mother's womb. Then came the the CT scan, where Professor Sir Hounsfield was given the Nobel Prize for finding out the CT scan machine, where the section of the bodies can be done without even opening it up, and then you can have a different, definite diagnosis. Around the same time, around the 80s, came the MRIs and also the PET-CT, where it could be detected the presence of the tumor cells or the cancer cells in the human body without and localizing them with the use of the radioactive isotopes like the fructodeoxyglucose. And then the automatic analyzers were there, where we have been able to investigate and find out the blood samples, hemoglobin, TLC and other parameters being done without going through the hemoglobinometer or the WBC pipette, which you used to do it in our physiology classes. And the analyzers have come, and nowadays the things have come where you can, even without the investigations also, you can put your hand, and then with the sensors you can detect the hemoglobin level and the other blood parameters. But what has not changed over the years is from the black and white era to the color era, that the patient coming to the doctor and being examined by the doctor. And if you see, take a person, this is a common thing which you find in the internet. If you take 5 blindfolded people and try to examine an elephant, 5 people will give 5 different opinions. And unnecessarily, if you are Googling to find out about a condition, it is going to add to your stress. And the AI, hospital which has been, developed in China, which you would have heard about it, what they do is, the patient goes there, writes the symptoms, gets some medicines for there. But how do you elicit the clinical signs which are monitored by the patient, by the doctor? And from where do you, get the sympathy and the compassion that you get from the doctor? You might have remembered this movie Robo, where Chitty goes and saves a girl from the fire. But unfortunately the girl commits suicide because he forgets to put a cloth on her. And that is what the doctors do while examining the patient. Not only they provide the treatment to the patient, but also they show the empathy and the communicate and compassion to the patient. And medicine is not just an form of science, but it's also an art. Physician are the primary care providers who make the diagnosis and prescribe the medicines. Clinicians are of paramount importance and cannot be undermined under any circumstances, and therefore the future is always going to be collaborative, where the future healthcare is about not replacing the doctors, but about augmenting the performance of the doctors. Thank you.
Dr. Uday, you can have 1 minute for rebuttal each. 1 minute.
Thank you,
We'll
ma'am.
open 2
I
minutes
will
for
adopt the
audience.
order. We all using mobiles, and we need to keep updated our mobile data. If we don't update our mobile data, it will be of no use. So technology teaches us that we need to be updated. Definitely, it is not going to replace the human expertise, but it is going to change the approach in clinical medication, and I think what is the theme of the debate. So the role of doctor is changing from being the primary source of data generator to interpreter of the data by means of all this innovative technology, a validator of those data, and effective communicator of those data to the patients. Thank you.
As we have seen, there is a progress of the science in the physiology, in the physics, and that has been implemented in the human treatment, because what we want is the treatment should, the patient-centric care should increase, and the patient is provided and gets the benefit of the researches that are going on. And that is how, as you have seen in today's presentation also, the the investigation specifically, in the pathology where they are going into genetics, genetical markers, and then the cytogenetics where they are investigating and doing, finding out the genetic, the genesis of the disease and the cancer cells, and targeting them with the medications which are available. So the treatment part of it, the inclusion of the medical investigation facilities or whatever is developing in the future has to be incorporated into the human, into the medical field, and that is how we can also give a better patient care, and the doctors are also going to be the prime importance in providing that. Thank you.
Thank you. So show of hands in support of Dr. Uday now. Very few, but you have increased your numbers. So, yeah, any question from the audience? Thank you.
Thank you, contestants. Now, the moderators will be felicitated by the chairman of the organizing committee, the scientific committee, sorry, Dr. Ajit Karmakar, sir. Thank you, participants. Now we move on to the second topic, diabetes mellitus reversal. Is it a myth or reality? So for the reality is Dr. B.B. Karunamay from BSL Bokaro and Dr. Jayant Kumar Acharya as myth from RSP Raukela. Please requesting all the contestants to stick to the time frame given to them. To moderate this session, we will be having Dr. Jitendra Sarangi, CMO ICRINL Vizag, and Dr. Rupak Goswami, CMO DSP.
का नाम क्या था सर? Good afternoon, respected chairpersons, dignitaries in the dash, and my dear friends. Diabetes mellitus is a long disease in entity in the fraternity of medical sciences. So my topic is diabetic mellitus reversal. Its reality as because we are moving beyond management to metabolic recovery. It requires a lot of emphasis on the lifestyle and other measures apart from the medicines, as we going to witness the hazards of the epidemic of diabetes by next few 10 to 20 years. Reversing diabetes, there is a shifting of concept from medical myth to scientific reality. There is shifting in paradigm of the disease conception and definition. Earlier days, when we are a graduate in the student of the medical science, the definition happens to be it is a chronic progressive irreversible disease due to absolute or relative deficiency of insulin. But what is the modern reality? It is a metabolic dysfunction which can be reversed. Now, the reversal is often used interchangeably in many of the diabetic trials, but remission is the most preferred terminology in all the guidelines after sustained normal glucose without drug. And this also proves the optimal terminology used during the different interventions when the favorable outcome comes as a resolution, reversal, remission, or cure. The ADS consensus group also prefers or recommends the terminology of remission. So, when to say it remission, when we achieve a HbA1c of less than 6.5, at least for 3 months without any medicine, then it is defined as a remission. What is the current pathological reality in this metabolic disorder? It is being driven by excessive fat in our visceral organs like liver and pancreas. What is that happens or it do? Basically, the fat in the liver causes insulin resistance, and in the pancreas it clogs the beta cells and reduces the insulin secretions. For decades, we are knowing about the NAFLD, which really is a strong link in a bidirectional entity and is a harmful entity which causes the deposition of fat in liver and culminating to the insulin resistance, and again it leads to the increased fat generation and thus insulin resistance. In pancreas also, if deposition on fat causes impair in the insulin production, the lipotoxicity, damaging the beta cells and reducing the responsiveness to insulin and contributing the insulin resistance. Thus, the key factor in remission is the reduction in the body weight to the tune of 10 to 15%, then it drives the beta cell reawakening and thus improves the insulin sensitivity and secretions. The proven strategy is the low calorie diet, the low carb keto, and the bariatric surgery has a major role along with the exercise. ADA supported approaches are, apart from weight loss, are the dietary overhaul. Now the millets, the fruits, the veggies has got an important role in our dietary, and the regular exercise has a major role along with the stress management. Apart from the medical management, the surgical management has a great role in achieving the remission in terms of bariatric surgery, which induces a remission of to the tune of 80% for a period of 7 to 12%. But who are the candidates? It is the candidate in the initial phase of 0 to 6 years who are more sensitive or more fruitful for the remission, and the beta cell factor is a major factor. After 10 years of disease who are on insulin, remission is very unlikely. So, what are the clinical evidence as of date? The major landmark trial in the diabetic remission is the direct trial, which showed around 46% of remission after 12 months, and it sustained for 5 to 7 years. The other trials also showed in a positive line, and in a meta-analysis for a review articles, it showed also that the remission is possible, but the long-term consideration and susceptibility for its effectiveness needs to be monitored. Challenges are, the major challenges are the relapse. So the take-up message is that the T2DM can be go into remission, and the key factor is the early diagnosis and sustained effort and monitoring is required. Dear friends, we might be seeing in our roads and different posters that say bye to diabetes in 90 days. घंटों में रोग मुक्ति diabetes type 1 and type 2, like these posters are always we are seeing. The छोटी सी बच्ची की बंद हुई इंसुलिन, but is it possible? We should be honest with our profession, and scientifically we should guide our patients. Thank you.
Good afternoon all. With due respect to my previous speaker, I'll just put some highlights. Ki reversal of diabetes, is it possible? What is the answer? Well, the answer is no if we go by literature, and the answer is yes if we exchange the term reversal. The normal not there, because if weight regain is always a risk factor for the disease recurrence, and the consensus say that you should use the word remission instead of cure. So cure is not possible. So why it happens? Because it has a inherited genetic fixed blueprint of combination of multiple genetic variations, and these variations occur at the germline level during the conception period. So it is inherited and permanent with a fixed architecture. It is not like the lipids or proteins that can be degraded. And even if you go into a metabolic remission at any phase, you still carry more than 150 genetic risks which can cause a relapse whenever you change your lifestyle. And this process is so complex, and the variation is so complex that there is not a single switch where we can intervene and you can say that you are cured of diabetes. So let us discuss the three main pillars of intervention which is for remission. First is the medications which salvage the beta cells. Second is the lifestyle modification which will help to decrease your weight. And third is the pediatric surgery which will also help to decrease the insulin resistance. So we will discuss each pillar and see what is the outcome. So see, in fact, coming to the medical intervention, short-term intensive insulin is the key factor which eliminates glucotoxicity related damage to the beta cells and helps to salvage the beta cells. With other oral drugs, mainly the GLP-1 receptor agonists, which help to decrease the weight. Now, lot of work has been done on this, but let us see what is the outcome. So, this is how the insulin helps to decreases the glucotoxicity, and at the cellular level, it decreases the oxidative stress to the beta cells. Now see, this is the summary of the key studies where they have compared the outcome at different years of intervention. So if you see, in these four major, the latest is in 2023. So you see the remission effect of the pharmacological intervention, it wanes off at 1 year. Next, coming to lifestyle intervention. Basically, low calorie diet or Mediterranean diet or ketogenic diet, whatever you say, with exercise. So basically, they reduce the fat deposition in the key vital organs and they help to reduce the weight. But does it help? See the long-term effect. At 4 years, the remission effect is gone. By 12 years, you are back to the same stage. Now the most voted intervention is the metabolic surgery or the bariatric surgery. It was said that it does wonder to obese patients. How does it act? These are the various type of surgeries, out of which this sleeve gastrectomy and Roux-en-Y, they are the most voted for. What they do is, they decrease the gastric volume, decrease the appetite, increase the anorexic hormones, so you will eat less, low calorie, there will be weight loss. But does it help? So ultimately, hypothetically, they increase the insulin sensitivity in the different organs. But does it help in long term? See, this is the summary of 10 major RCTs. And this is a long term follow up of this bariatric surgery, what is the output. See, these are 10 major, and you can see the latest is in 2022. So what they are showing is, it helps, but the remission effect slowly wanes off after 2 years. At 10 years, majority of the studies are not voting for this surgery, and at the end of 12 years, you are back to the same stage. Even there are many surgeries who have said that there is relapse of diabetes after the metabolic surgery, and they have also postulated theories that longer duration of diabetes before your operation is a key factor for later relapse. So that means relapse will be there. So these all studies, they say that relapse will be there. So the remission is not long lasting. So take home is, diabetes mellitus is a chronic progressive disease which has a complex pathophysiology of genetic and environmental interplay leading to progressive beta cell failure, making it incurable. However, remission can be achieved by combination of various modalities towards weight loss if used early. Predictors of higher probability of remissions are younger age group, lower HbA1c level, absence of insulin use before intervention, short duration of the disease. So if any person is having diabetes, what I say that if you are crying for this disease, it is acceptable. You are tired of this disease, it is acceptable. You are very anxious of this disease, it is still acceptable. You are stressed, you are still acceptable. You are angry, still acceptable. But quitting for remission is not acceptable in diabetic diabetes. So you should keep on trying to change your lifestyle, keep on adhering to your medicine, so that at least theoretically you are in a state of remission, not cure. Thank you.
Thank you, sir. I think my opponent colleague very nicely said the diabetic has two factors, the genetic and the environmental factors. Rightly, as we age towards the decades of in our life, the diabetes comes in the third or fourth decade due to our lifestyle changes, due to our obsogenic habitus. So why it had not come in the decade 1 or 2? Because many of might be the genetically predisposed for the disease, but the disease happens in those particularly where the environment factor do act. So in that way, if we consider and we modify the environmental factor, our diet, lifestyle, then remission do happens, and it should be taken in the earliest of the disease diagnosis when there is not much of the beta cell exhaustion. So it is possible for a very handsome years to live with remission life. So thank you.
Dr. Jain, rebuttal to what he said, if you want to stress anything further.
Yeah, I should just like to say one thing, that there should not be people should not go from this conference that I don't want to demotivate people who are having diabetes. But the thing is, there is hope if you basically disrupt the link between the genetic factor and the environment factor. So that is in your hand. So you can always comply to drugs, and you can always change your lifestyle, and you should not take away that if I do this for this period of time, then I will be out of this problem. And the main people who are culprit to this chain of events of feeding wrong input to your brain is the media, where you can see in the Google that once you type the remission of a cure of diabetes, you will be flooded with information how to be permanently cured. At least that should not be there in us, and we should follow the golden principle of balancing our lifestyle and comply to your medication, so that you are not landing into complications, irreversible complications of the disease. Thank you.
Thank you. So now the house is open. Any questions for the panelists? If there are no questions, then we want the people who are sitting in the hall to raise their hand who feel that diabetes can be remission. Yes, can be brought to remission. Yeah, there are many people who believe that it can be brought to remission.
Thank you. To felicitate the moderators, I would request the chairman of the scientific committee again. And I request Dr. Rupa Goswami to stay behind. Next session up. So the third topic, Dr. Rupa Goswami, please stay back. Dr. Rupa Goswami, sir, please stay back. The next topic today is artificial intelligence in medical science, whether it is a boon or a bane. So for that, I would request Dr. Vinita Singh from Tata Steel and Dr. Rupa Goswami from DSP to please take the podium. And the moderators are Dr. Rajanjan Kumar sir, CMO IC, DSP and ISP, and Dr. K. Thakur, CMO Bhilai Steel Plant.
His interview is This is timer. Topic of discussion is artificial intelligence in medical sciences.
Can I see it?
बून में डॉक्टर विनीता सिंह.
Good afternoon, everyone. I'm here to convince you all that AI is a powerful tool in a clinician's armamentarium to provide a more safe, effective patient care, and it has the potential of upscaling to a huge population in areas where it is applicable. So why AI in healthcare? So the medical knowledge or data is growing exponentially to the tune of doubling of data is happening every 2 to 3 years, and it is far beyond a human brain processing possibilities. So what AI does it helps you warning system score where it predicts and screen or risk stratifies patients who are at high risk even before full clinical deterioration, allowing interventions earlier, reducing ICU transfer and improving outcomes of the patients. Now, clinical decision support. This is one area where AI actually collates data of patient-specific input which you get from the history and combines it with evidence-based guidelines, and thereby assisting the doctor, who is the ultimate decision maker. No matter how much AI comes, it is not working in a vacuum. The ultimate authority lies with the doctor. All it does is helps you with a better informed decision. The other area also, clinical decision, it is very effective, is it has the potential of reducing medication errors by 30 to 40% by providing you full backup history of the patient and giving you warnings and critical alerts. Regarding clinician burnout, we know more than 50% doctors, especially younger doctors, perceive it more than older ones. But AI-assisted documentation reduces administrative burden of clinicians by about 20 to 30%, allowing you to enjoy your clinical practice in your actual field of practice, and increases touch of doctor and patient, and so that you enjoy what you have chosen to be or practice. Now, India has a huge challenge of a urban-rural divide in terms of healthcare delivery options. So AI is very useful in this area, and Government of India is working heavily on this. ABDM or Aismoc Bharat Digital Mission, and there are several AI-related projects which are happening. And what it will do is, because of the shortage of specialists in far remote locations, AI-enabled screening, risk stratification, and screening out patients who actually need referral would be earlier, and eventually it will improve outcomes and save lives. Now, many of the speakers today have already covered this subject for us, and precision and preventive healthcare medicine. This is one area where it debunks the theory of one size fits all, and depending on, because AI can apply genomic sequencing, and it will actually tailor-made treatment or individualized treatment can be offered to patients. Now, coming to some misconceptions which are there. Will AI replace doctors? Certainly not. It actually just handles data. Doctor handle the decision making, and it's a wonderful example is radiology, where AI has actually come in a big way. But we have seen now that radiologists have moved on to preventive medicine. So you could actually it will change the style in which you work, and you could actually focus on better things. AI makes mistakes and can't be trusted. These are some of the misconceptions. So the real danger isn't AI making mistake, it is ignoring a tool which is provided to us or will be provided to us to reduce the errors and mistakes. Patient data won't be safe. That's not true, because like every application, we have safety mechanisms. We protect our case sheets, we protect our digital health records. Similarly, there should be a mechanism of securing data with AI. It is biased and unfair. Surely, unlike human, who actually suffer more bias, but which is hidden and subtle, AI bias can be picked up and it can be worked continually to improve, because what is AI is just collation of huge amount of data which can be worked upon if there is any bias felt. And certainly it will be less than the doctors. It lacks empathy, that's the other, but no, that's not true. What AI will do you, it will save you, protect your time in a better way, decrease your screen time, and you can interact with your patients better. Developing countries cannot afford AI. As I said, India is working heavily on it, and one AI tool can serve millions, and actually scaling human resource to that extent would be more expensive than AI applications. Technology failure, we have ventilators, scanners, monitors, name it, all can face this. So similarly, AI could also face this, but we have to have oversight and mechanisms to work around it should that happen. So to conclude, I would say opposing AI in healthcare is not protecting patients, it is denying them progress and safe environment. The real ethical failure is refusing a technology that can save lives and expand access to care. AI will not replace physicians. However, physicians who use AI will replace those who don't. And in medical practice, it's not far away from us. In a few years that it will be coming at our doorsteps. Thank you.
Good afternoon, respected Vinita Madam, chairpersons, honorable judges, my dear friends. Today I stand here to speak against the motion that artificial intelligence is a boon in medical practice. So I have few points. First, do you feel AI, artificial intelligence, can feel or hear? As I stand here, although artificial intelligence is fast and modern, its uncontrolled use makes it more harmful than useful. First of all, medicine is all about human being and not machines. A doctor understands a patient's fear, pain, empathy. AI cannot even feel a patient. It works on the data and the algorithm which is fed into it. In critical situations, I think it's the doctor's judgment which is more important than artificial intelligence. Second, AI can make lots of mistakes. It depends completely on the data and the algorithm which is fed into it. Even a wrong data can lead to a wrong diagnosis. In medical science, even a small error can take a patient's life. So can AI take responsibility for it? No. Thirdly, over-dependence on AI. If doctor starts depending on artificial intelligence, then what will happen to the critical thinking and what will happen to the decision making? In medical science, in emergencies, doctors must depend mostly on their experience, not on artificial intelligence. Fourth is the data breach. AI is full of data, so even a data breach can lead to more harm and loss of trust. Moreover, AI increases inequality. Advanced AI is costly and limited to only big hospitals. Rural and poor people cannot afford it. Hence, to conclude, all I can say is artificial intelligence can assist doctors, but it can never replace human intelligence, their responsibilities and their compassion. So let us use technology wisely and not blindly. Because in medicine, one wrong click can cost a life, and no machine is going to take the responsibility for it. Therefore, I strongly oppose the motion and say that artificial intelligence in medical science is a bane and not a boon. Thank you.
So, my worthy opponent spoke about a few things, and as I said, yes, machines certainly cannot feel patients, but they are there as a tool to assist you to get to the right areas of, practice in medicine. They are not, so there's just an assistant tool. I mean, what about, we didn't have ultrasounds, MRIs, CTs, they've all come into our world and our lives, and we have still evolved and continued to care. But we cannot deny patients something which will actually improve their expectations or their safety just because a doctor is stuck to their own decision making. So it's not about our decision, it is about denying something which will enhance patient safety. And already in young techies and all, they are using co-pilots, they have their own history and they come with their prepared information. And if we don't take help of AI, then we will be lagging behind. We will not be able to answer all the questions which will come from their end. So I don't agree to that. Regarding rural, several years back when smartphones came, we didn't imagine how it would be in India. And today, nearly everyone has a smartphone. And so similarly, AI mechanisms will be functional through smartphones, and the government of India is doing a lot of jobs. So I don't think that also holds true. So that's it. Thank you.
Madam, I have few points to make. What happens if AI makes a wrong diagnosis? Will the doctor take the responsibility or the machine? What happens if the AI system fails due to a software bug or a cyber attack? We are going to lose huge sensitive data. Another important thing is, can AI fully understand a rare case or a atypical case? I don't think it does, because it is totally dependent on the data which is given into it, fed into it. Will AI reduce the job opportunities? There's a question. For young doctors, what will happen to the young doctors? And could over-dependence of AI reduces or weakens a doctor's, as I said earlier, a doctor's skill or a way of thinking? That's my small points. You are very good in it. Thank you.
Any question?
Good afternoon, sir, ma'am. I think excellent. Both have put up their points, but the concern here is that we have to adapt to AI sometime or the other. I think the world is in that line. Maybe we are a little slow if we talk about a country, but that is how it is, and we have to look not at the nuances, but we have to look at the positivities that is there. In fact, the errors, the connect, the time, and all that anticipation and the prediction that we were trying to gain all these years, now it is actually possible with AI, and we have to take it forward. Whatever said and done, I think it's high time that we understand, because we are still lagging behind where the world has taken big leaps and bounds. So we'll have to. It's not just that talking about any change is kind of different or it's not very welcome. But I think this is something which we have to adapt to, and I think we have to get it forward. So let us look at the positive aspects on this, whatever has been told. But the point is that it's not going to interventional still. If the database is wrong, I think everything falls. I think it's what Dr. Rupak wanted to highlight. But if we have to take, it's on a larger database that we work upon. the errors, you talk about one error, I think we are doing thousands of errors during our practice. So I think maybe that AI is going to take care of that error which is going to happen. But these are just 1 or 2 points. But overall, if you have to take a message, we have to learn to adapt to the AI. Not replacement, but actually to take it as an aid or a help for that. Yeah, please. Yeah, sir.
This is off the track. There is a lot of apprehension for the all NEET PG जो बच्चे लोग अभी जा रहे हैं काउंसलिंग में. They have started thinking that radiology, pathology, dermatology, gradually they will lose their magnetism what they are having now, and maybe they have a very huge apprehension.
So regarding radiology, I suggest you look into the YouTube. There's a beautiful video by a AIMS graduate who did his masters in radiology, and he picked up AI, and that's his subject where he's working. And he speaks about how the Western world now is moving from diagnostic and therapeutic radiology to preventive radiology. So it has come back. So I forget the name of the person, but when I get it, I'll share with you. It's a very good video where he explains that. So other options will open up. Even in pathology, preventive pathology will come up in a big way. And sir spoke about it this morning also. So we just shift from where we were, and it's not very far. At least in medicine, pathology and radiology, it's not very far away.
And what about hospital administration?
That there are wonderful automations and AI-enabled practices, because I didn't touch that, because just the clinician, but there also there are very good products coming which enables and upscales your performances.
Sorry, time is up.
Thank you, participants. It was an excellent session. So to felicitate Dr. R.R. Kumar sir and Dr. K. Thakur, I would request the coordinator of Aismoc, Dr. Patil, to please be on stage. Now, from being the moderators, Dr. Kumar and Dr. Thakur will be the next contestants, I should say. The topic is hospital management, whether it is for the doctors or it is for the professionals. And for the moderating the session, I would like to call on Dr. B.B. Karunaman, ED Medical, Bokaro Steel Plant, and Dr. Jayant Kumar Acharya, CMOIC, Rourkela Steel Plant.
Docs file, what file?
ये फुल स्क्रीन है सर, ये पहले वाला स्लाइड है, सेकंड स्लाइड, थर्ड स्लाइड यहाँ करना केवल, हाँ
Good afternoon to all.
Sorry, Doctor, we have got a esteemed guest, Dr. Ramachandrani here, and I have promised him that I'll give him the session from 1 to 1:30 because he has to catch a flight. So we are getting late, and if this debate continues, he will be further delayed, may not miss this. Sir, this side, sir. So I had requested, sirs, that we make some concession for this session because you are all here, and he has come all the way to give us the... So, just before this session, so please be here with us. Thank you, sir. Thank you for it.
I'm so sorry for interrupting in the program. I come all the way from Hyderabad. I was not knowing that my schedule is so tight. But anyway, no. Mohan, where is my today is not there. I put there. No? How will we know? She has not come. No. Can I use my laptop? They have not shifted. This one.
This one.
ठीक है. Okay. Fine. So, good afternoon, everyone. We are now going to start the next guest lecture, and this is by Dr. Mohan Ramchandani, who is the director of the interventional endoscopy at the AIG hospitals at Hyderabad. To give a brief introduction about Dr. Mohan, he is an internationally acclaimed gastroenterologist and interventional endoscopist, currently serving as the director of the interventional endoscopy unit at AIG. With over 19 years of experience, he is widely recognized for his pioneering contributions to advanced therapeutic and third-scape space endoscopy. And today also he is going to speak on this advanced therapeutic endoscopies. He is a graduate and postgraduate from Gandhi Medical College, Bhopal, and has completed his GM from the BHU, Varanasi, and then he has done his advanced expertise through specialized training in endoscopy in Japan and China. Now the stage is all yours.
Thank you so much, sir. I think I got a lot of videos. Actually, I was preparing my talk regarding advances in endoscopy. Endoscopy has really advanced now, and I'll tell you the present scenario of cancers in India. And we deal a lot of patients who come to us with dyspepsia, like in an asymptomatic stage. So we have a huge opportunity and responsibility to diagnose these cancers early when we can treat them. So that's what I wanted to show in my slides, that at present our cancer-related mortality is very high. Say for example, esophageal cancers, at 5 years, if I diagnose cancer today, but when I go to doctor as a dysphagia, because the disease is almost now engulfed the lumen of the esophagus, when I go to doctor, they do whatever they want, surgery or do whatever, chemotherapy, radiotherapy. 5-year survival rate is 20%. Similarly, in stomach, if I go to doctor with symptoms of gastric outlet obstruction, by the time the tumor has gone into the lumen and obstructed the duodenum. That means if you can see my slides, this is the data from a very advanced cancer institute in India, and they show the 5-year survival rate is around 30% for the CS stomach. So this is the present scenario. But what we as endoscopists do is to bring down to the level of Japan. Now see, in India, the stomach, the upper GI cancers rate is this much. Most of the patients die. That means incidence is equal to mortality, almost. But that's because we are treating our patient who are symptomatic, and by the time they present to us, they are in advanced stage. While in Japan, the incidence is high, but mortality is less. Similarly, in China also is happening similarly. Why they are doing like this? Because we are seeing our patient in a symptomatic stage. Say, for example, as I was talking to you, the patient has presented with dysphagia. He has fungating mass in the esophagus. He is not able to swallow. What about if you do endoscopy and have some technique to diagnose these cancers in early stage? Because if the cancer is starting with a polyp and growing into a fungating mass, it is spreading from epithelium to muscularis propria to submucosa and to muscularis propria. And I'm talking about the gut wall layer. And as the depth is increasing, the lymph node metastases are increasing. That means if you can diagnose these cancers in very early stage using very simple technology. I'll tell you about our institute where we used to do endoscopy in such a way. I don't know how many you do endoscopy, but I am telling you about an endoscopy where we do endoscopy without preparation. Like patient come, sleep, do the endoscopy and watch for bigger tumors like here. So you see a lot of froth, you are not exposing the mucosa. But now what we are doing is we are giving the patient some preparation like anti-bubbling solution like semethicone or mucolytic solution, N-acetylcysteine, simple medicines, and cleaning the mucosa. Once you are cleaning the mucosa and spending some time, now this endoscopy may be normal for anybody. But once you have a very nice clean endoscope or picture, you don't ignore these such nodules. Now this is a cancer. So this is a 5 millimeter cancer in the stomach. By and large, it will be like a normal. So we are using a lot of imaging technologies like narrowband imaging, but the most solutions are simple. Clean the stomach, distend it well, see small micro nodules which are cancer. And once you diagnose such cancers in very early stage, like this is an example of a cancer of esophagus. Now you see this patient has come to with dyspepsia. Now once you see the narrowband imaging, you will start seeing a patch. The lumen is still not obstructed. The cancer is still in the epithelium. It has not gone into submucosa or any muscle problem. You know, this patient is not dysphagic. And you apply this narrowband imaging technology and you will see these IPCL. So what we see is changes in the vasculature of these small patches and diagnose these cancers in very early stage. Like example, this is a Barrett's esophagus, where you find a patient with chronic reflux, there is a Barrett's, and then there is a nodule which has turned into cancer. Now these Barrett's cancers can be easily removed by endoscopically, not only the diagnosis, but also we can remove them, completely remove them by using ESD technique and remove these cancers completely and subject them to histopathology. Then histopathologists tell us about the depth of the cancer, whether it has gone beyond the submucosa or it is touching the muscularis mucosa. So based on that, curative resections are diagnosed. So now this scenario is now matching with that of Japan, China, even the South Korea, where we are able to diagnose these cancers in asymptomatic, say for example in a dyspeptic patient who came to for another problem. But once you do such type of investigation and diagnose these cancers in very early stage, you can remove them endoscopically, and it is 100% curative. Not only by endoscopically, but you have a full histology specimen available where pathologists will declare, okay, this is curative resection. So now think about a scenario where everybody does endoscopy in such a way in India, and you are able to bring the difference between incidence and mortality. Not diagnosing these cancers in a very advanced stage where palliation is the only option. So this we must go beyond that, and endoscopy is now progressing to microscopic level. We are able to diagnose cancer cells within the endoscope itself. Like say for example, this is a colonoscopy being done, and a polyp is being seen which is yet not very advanced, and you can do an endoscopy, endocytoscopy. You can see by the magnification level, you can stain the polyp then and there only by methylene blue or a crystal violet, and do a real-time histology. Like I am doing here by spraying the methylene blue and seeing the cancer cells inside the endoscope, not even sending this specimen to the histopathology. So this is known as endocytoscopy, which gives us an option of treating these patients, not only diagnosing them in very early stage. So this was about the cancer. What about the other disease which required a treatment in the form of surgery? These are the treatments which are now being offered by endoscopy, where we are able to peel off the mucosa from the muscle. Now the disease of the muscles are different and disease of the mucosa are different. Say for example is esophagus. Now esophagus is a mucosa where cancer can cause a polyp or a patch which can be removed if you are able to separate mucosa from the muscle. Similarly, in achalasia cardia, muscle is the problem. The muscle is not relaxing. The patient has severe dysphagia because LES is not relaxing. Now, up till now, either we can do a Heller's myotomy to go from the peritoneum and cut this non-relaxing muscle, keeping the mucosa intact. The similar thing can now be done by endoscopically, and this is known as peroral endoscopic myotomy, where we can cut the mucosa, separate the mucosa from the muscle, and that is known as third space endoscopy. Now once you separate the mucosa from the muscle, and now you know the muscle is diseased, so you can remove this muscle by cutting it completely. You can cut this muscle underneath the mucosa, keeping the mucosa intact. Mucosa is a very robust structure. Even if you remove the muscle, mucosa, if it is there, it will prevent the contamination to the mediastinum, to the peritoneum. So once a patient with achalasia cardia is there, now no more Heller's myotomies are done. We can do underneath the mucosa peroral endoscopic myotomy, and these are known as scarless surgeries, where we are able to go into the submucosa. And that is why this is known as third space endoscopy. So this is the normal lumen, and now you are able to create another lumen between the mucosa and the muscle, so that is known as third space. And that is how these are being not only in achalasia, but also, like say for example, a patient has long time diabetes or the patient has gastroparesis. Now these patients can also be treated by pyloromyotomy. Similar to the LES myotomy, you can do pyloromyotomy. That is all endoscopic. Another issue is that you must create only a window has to be created between the muscle and the mucosa, and then you go between the muscle and mucosa and cut the muscle, which is spastic here in the pylorus, which is not allowing foot to go down. So this is a treatment of idiopathic gastroparesis also. So this is how the endoscopy is progressing from treatment to many other things, like removing the tumors from the gut wall. We see so many patients with GIST, so many patients with leiomyomas, which can be removed by these technologies by endoscopic method. Up till now, we were trained to remove only epithelial tumors, but now we are able to remove these tumors which are arising from the muscle by creating these tunnels and going between the mucosa and muscle, and then removing these very large tumors which up till now required surgeries. So that's an advancement of third space endoscopy which we practice in the advanced therapeutic endoscopy, removing these big tumors which are responsible for dysphagia, and also they can turn malignant, especially when you are treating gastrointestinal stromal tumors. So that is the way the things are progressing in the field of third space endoscopy. I will not go into the more details. Neuroendocrine tumors can now be easily removed from the gut wall using endoscopic treatments by using many safe techniques. Now this is a very small rectal carcinoid which is the propensity is for metastasis, and you can use such a certain clips to completely remove from the muscle base, and you can get rid of the tumor, not only the tumor but also the surrounding normal structure which will allow us to evaluate for R0 resection. So this is how these clips known as OTSC clips are being used to remove these cancers in a very easy way. In a 5 minutes job you can remove all these things. The Zenker's diverticulum also is a very big problem for especially old people, where there is a esophageal lumen and then there is a Zenker's pocket, and now by either it can be done by ENT surgeon where they do cricopharyngeal myotomy, but we have got very easy approach now to just cut this septum between the esophageal lumen and the Zenker's diverticulum. So this is a very easy procedure now we are doing with the help of third space endoscopy, creating a space between mucosa and muscle and removing the division between the esophageal lumen and the Zenker's lumen by doing dissection. And you can see this is the muscle which is being cut underneath the mucosa, and then that will remove all the barrier between the esophageal lumen and on one side the Zenker's lumen, so that the patient can eat well. So this is another important methods. We are treating now esophageal Hirschsprung disease. Hirschsprung disease, in what happens is, in a child there is a aganglionic segment which won't relax. The patient has constipation because the rectum will be completely dilated. Up till now it required a major surgeries, but now with the endoscopic technique we can cut this aganglionic segment so that there is no more resistance for the stool to come out. And these are very sick child, they are not growing, they are failure to thrive. What we do is we do a anorectal junction incision, create a tunnel again separating the muscle from the mucosa, and then going into the sigmoid, up till sigmoid till we reach to the ganglionic segment, and then identifying these non-relaxing muscle and cutting that muscle completely underneath the mucosa, relaxing the aganglionic segment, so that you see that this is the tunnel which is separates the mucosa from the and you can see now we are going into the sigmoid which is dilated. So the dilated segment is in fact the normal segment because it is not able to empty because of the aganglionic segment, and the aganglionic segment which is not relaxing is being completely cut underneath the mucosa without surgery, endoscopically. So this is known as perrectal endoscopic myotomy. This is also an endoscopy procedure but has taken over in some centers to treat a short segment Hirschsprung disease. So there are many other things can be done underneath the mucosa. You can remove the cancers from the mucosa, you can remove the non-functioning muscle like in gastroparesis, achalasia, Hirschsprung disease. You can also do full thickness biopsies to ascertain the causes of pseudo-obstruction. So this is the era of third space endoscopy, where we are creating another lumen and doing so many things to treat our patients. I have some few more time, so I'll go into the other parts where endoscopy is really progressing, and one of them is ductoscopy. Now this patient has obstructive jaundice, and this obstructive jaundice is because of a mass in the hilum. Now in medical, of late we are also seeing a lot of benign disease causing this, like say for example IgG4 disease, which can cause similar hilar stricture, but if you give steroids, they could completely get to normal. Or there can be tuberculosis in India, which can cause similar hilar strictures. So up till now, what we do is we do ERCP and take brushing from here. And the brushing sensitivity is very low, around 40%. So in 60% of the time, we are not able to diagnose. But now we have scopes which can go into the bile duct, into the pancreatic duct, and this is known as cholangioscopy. And you can see now, once a patient has obstructive jaundice, we go inside the bile duct and see what we are dealing with. And this is a cancerous lesion into the bile duct. Similarly, you can go into the bile duct and see what type, and this is a lymphoma. So the ERCP picture, the CT scan picture will look same, like there is an obstruction in the bile duct. But if you go into the duct and take biopsies, see them, you will be able to pinpoint whether you are dealing with carcinoma, which requires surgery, lymphoma, which requires chemoradiotherapy, tuberculosis, which requires anti-tubercular treatment, IgG4 disease, which requires steroids. So to pinpoint the diagnosis, we are able to go into the duct and do all type of treatments. Difficult bile duct stones are no more a requirement for surgery, because you have now cholangioscopy guided laser treatments which can bust very big CBD stones or a pancreatic ductal stones under vision, and you can get rid of all these big stones, and no more bile duct exploration is required, or no more major biliary diversions are required for such treatments, because you are able to do it endoscopically and get rid of these big tumors. So the cholangioscopy and pancreaticoscopy are another big advantage of newer therapeutic endoscopy. Coming to the diabetes, and this has been endoscopic new treatments for diabetes, where duodenum is now thought to be the epicenter for diabetes, because constant exposure to the Western diet or a high caloric diet leads to duodenal mucosal hyperplasia, leading to imbalance between incretin and anti-incretin. So lot of new treatments are being planned for this, and one of them is duodenal mucosal resurfacing. Unfortunately, this video is not working, but what we do is we go into the duodenum and burn the duodenal mucosa by radiofrequency ablation or thermal ablations, and completely get rid of these hypertrophied duodenal mucosa. So this is the duodenal mucosa. You go into the duodenal mucosa, elevate by saline and burn it. Once you burn it, there is a resurfacing of the new duodenal mucosa, which brings back the balance between incretin and anti-incretin, and there are 4 or 5 big trials on this, which has clearly shown that if you undergo such DMR procedure, duodenal mucosal resurfacing, your HbA1c comes back to normal, fasting blood sugar improves a bit. So this is how the new diabetes treatment is being endoscopically done. Only thing is some recurrence, but this procedures can be repeated many times. It has been quite common in Europe, but in India we still have not been, this treatment has yet not been approved. We are also treating anti-reflux treatments by endoscopic methods, not by fundoplication. And this is one of the method what we call as GERD-X, and where we go into the G junction and plicate the G junction with the plicator so that we can create a fundoplication. And this is how we have done. Unfortunately, this video is not working, but it brings down, it improves the health related quality of life, improvement in heartburn, and also improvement in the regurgitation symptoms. So right from the cholangioscopy to DMR to endoscopic treatment of reflux to going into the small intestine. So this is a probe where we could go deep into the small intestine. Now this patient, small intestine problems are a big problem for gastroenterologists. Patients who have mid-bowel strictures or Crohn's disease, or there can be a polyposis syndromes where we need to go too deep into the small intestine, and we don't have any up till now any method to go into the small intestine. To go into the duodenum it's okay, to go into the colon is okay, but to go into the small intestine is a big problem. And then such strictures in the small intestine, which could be because of Crohn's disease or which could be because of tuberculosis, we are able to now diagnose and take biopsies, treat these strictures of small intestine by balloon dilatations, and remove the foreign body from small intestine is also possible. So this was spiral enteroscope, but there is a lot of development happening in, we have balloon assisted enteroscopy, we have spiral enteroscopy. Spiral enteroscopy is just been withdrawn from the market for few reasons, but we have balloon assisted enteroscopy, which also allows us to go into the deep into the small intestine, jejunum, ileum, where we still depend on the imaging like MR enterography, CT enterography, but this enteroscopy allows us to go not only take biopsies, see the lesion, but also do therapeutic procedures like dilatations of the strictures, which is very common in Crohn's disease. Ultimately, I think the endoscopy has evolved a lot. I talked to you about beginning from the cancer diagnosis, which is very close to my heart, and I really want India to progress in that way, what Japan has done. In Japan, we say that it is because of the screening, they are screening for the gastric cancers, but it is not. They catch the gastric cancer in so early stage in a normal clinic. And a patient coming for dysphagia, dyspepsia, they are just able to diagnose these cancer by meticulous endoscopy. And this is what we have started in our institute. We have around every 3-monthly training for endoscopists, how to do endoscopy, just normal endoscopy. So we call 25 doctors every 3 months and 2 experts from Japan, and we are gradually seeing the change in India, where we are able to diagnose these cancers when they are located to mucosa and submucosa. And these cancers are very early stage. And if they are not taken care of, they progress to obstructive symptoms and then incurable disease. So with this, I'll end my talk, sir, and will be happy to interact. My job was to talk about advances in endoscopy. With limited time, I could do what I personally do in my things, but there are so many new advancements. We can talk and talk, but we will be able to answer if there are any questions or if there are any doubts, we will be able to share.
Thank you, sir. You are for excellent presentation. I don't think there is a scope for question and answer session, and sir also has to catch the flight, I think. But still you can ask question, 1 or 2 questions, and sir will be happy to answer.
What about hiatus hernia? Hiatus.
Hiatus hernia.
In children.
Yeah. So unfortunately, we are not able to touch the hiatus. Hiatus still require laparoscopic repair. For non-hiatus reflux, endoscopy has got a big role. We are doing a lot of treatments in the form of device-assisted treatments. We are also doing ablation-induced treatment to induce the LES contractility. But hiatus, once hiatus develops, that means there is a problem in the diaphragmatic hiatus that is endoscopically not treatable at present. In fact, there are a lot of treatments in a hybrid way, like a patient who has a severe reflux because of hiatus hernia, the patient undergoes hiatal repair, but for fundoplication is not done laparoscopically. It is done endoscopically, because if laparoscopic fundoplication has got many other problems like gas bloat syndrome or severe dysphagia, which is not seen with endoscopy. So hiatus is taken care by laparoscopy and LES remodeling is taken care by endoscopically. So this is known as hybrid treatment of GERD, the GERD, and has got minimal side effects.
Thank you, sir. Our most of the still hospitals are having endoscopy facility, and they are doing.
Yes.
And your talk definitely will be very much informative for them, sir.
I'll invite all the people who are doing endoscopy to visit AIG to have a knowledge about how to do endoscopically, because unless we develop our habit of doing endoscopy in a structured way, we will miss it. We'll miss some corner, or will not pay attention to a small nodule. But once you have a structured training for doing endoscopically, we will be able to do much greater service for our patient in diagnosing these cancer early. Any patient who has obstructive symptoms, like there is a tumor in the esophagus, anybody can diagnose. But our aim should be to diagnose them once they are non-obstructive, once they are really beginning in the mucosa, so that the overall survival improves.
Thank you very much, sir. You have demonstrated everything very convincingly. Thank you, sir. Thank you.
Now I request Dr. B.B. Karunamai to please felicitate our guest speaker. Thank you, sir. Thank you, Dr. Karunamai, sir. Now I would like to request Dr. Patil and Dr. Sarangi to stay behind to be felicitated by the organizing secretary, Dr. Rajiv Kumar. Thank you, sirs. The last debate, the last topic of debate has been left, but as we are already running late, I think we should all go out for lunch. And the last topic will be taken up in the post-lunch session. So thank you. क्या रिव्यू लो
মাইক্রোফোনের সুইচটা অফ কর, মাইক্রোফোনের সুইচ অফ কর, মাইক্রোফোনের সুইচ অফ কর।
এটা দেওয়া যাবে না বুঝলে, আমার প্রবলেম হচ্ছে ওখানে দিয়েছিলাম
সুইচটা ঢুকে যাচ্ছে। স্যারের কাছ থেকে দুটো খাবার নিয়ে খাবার দিচ্ছে।
কি কত এটা কি
নিয়ে গিয়ে দেখ,
এই তো এখানে নাম্বার বলো না।
নাম্বার বললে মিউট করতে পারবি।
Check. Hello, 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 hello.
আমি তো জলের মতো এরকম মানে মনে ছিল সাঁতার কাটবো, এটা তবু
না না ভালো, মানে এখান থেকেই মনে হচ্ছে এখান থেকে প্যাকেজিং করেছে। এটা না
হ্যাঁ কেন অফ করলে
এই তো কাঁচিটা এটা খুঁজে বেড়াচ্ছিল সবাই।
আসেনি আমাদের আনতে গেছে। তোমাদের তিনজনের ওদের তিনজনের দিয়ে আমাদের চাকরি আনতে গেছি।
আমার বাদ দিছি আমার কই দেখি বেরিয়ে জায়গা আছে মনে হয়। না না ক্যামেরাটা কেউ থাকছে না, না ব্লক করবে ওগুলো সবই আছে না, ব্লগ ভিডিও করো খাওয়ার সময়। না না আমি তো ফালতু
সে বললো দাদা বললো কি বললো তোমাদের যে আরেকজন যে সিনিয়র ছিল সনদাকে দিয়ে দিয়েছে সনদাকে দিয়ে দিয়েছে
Hello. Hello, hello. Hello.
YouTube sound.
Hello.
আরে 15 থেকে 20 মিনিট 20 সেকেন্ড লাগে। হ্যাঁ ডিলেটা ঠিক আছে কিন্তু নয়েজ আছে। আপনার আওয়াজ এখান থেকে কি করে যাচ্ছে? হ্যাঁ আপনার আওয়াজটা কি করে যাবে? মানে মাইক আছে কোথায়? না তাহলে ডেস্কটপ কিনছে। এখানে কার একটা খাওয়া পড়ে আছে। এই নাজিবুল দা এখানে খাবার পড়ে আছে।
ওইটা তোমার খাবার আছে, তোমার খাবার ওটা খাও।
আমার স্যার এখানে একটা আছে ওটা কাউকে কথা ব্যথা হচ্ছে জুতো টাইট জুতো পরে ব্যথা হয়ে গেছে। তুই তাহলে ওখানে গিয়ে খেয়ে পরে দেখো 5 মিনিট হ্যাঁ সবই শুনি। মাঝখানে একটা কেবল গেল 30 মিটার এই 15 মিটার নতুন আমি একটা ইউজ করি লাগবে না। প্রত্যেকটা কম্পোনেন্ট একটা কেবল না লাস্ট ইয়ার ছিল তো ইয়েতে আগেরটা তো জানি এই যে একটা যেটা ব্লু খারাপ হয়েছিল আগে সেটাও দুর্গাপুরেই খারাপ হয়েছিল। না না তারপরে না আচ্ছা হ্যাঁ ওটা তো এমনি ফাংশনালি খারাপ হয়ে গেছে ছোটো ওটা ড্যামেজ হয়নি। আর দুর্গাপুর ভিডিকনে একটা খারাপ হয়েছিল যেটা মাথা নিয়ে গেছে। না ঠিক আছে এখন টোটাল আমাদের 15 19 20 23 আর আপনার কটা 3টে একটা পেশেন্টের 4টে আর 3টে শর্ট হসপিটাল ফেরত বলো চলছে ভালো। কটা ছটা স্যার যেখানে বসেন ওখানে রাখা আছে 3টে ব্যাগ আছে 2টো করে আছে। একটা ব্যাগ খালি কি করে হয় হতেই পারে 3টে ব্যাগ ভর্তি তাহলে তাহলে আরে তাহলে দেবনি না ওই দুটো মেয়েকে যারা কাজ করছিল অফিসে তাদেরকে দিয়েছে কাজ করে। ওখানেই থাকবে ছোটা ল্যাপটপ পুরো ফুল ফাংশনাল রেখে তাহলে কেউ দিয়েছে কাউকে মানে ইউজ করার জন্য যারা আমাদের অফিসে যে কলিগ করছিল তাদের একটু খোঁজ নিয়ে দেখো দেবরিনাকে বলো খোঁজ নিয়ে। আমার কাছে এখানে 14টা আছে টোটাল 20টা ল্যাপটপ আছে আমাদের অফিসে 14টা আমার কাছে আছে 6টা রেখে দিচ্ছি। 2টো HP পাবে না 4টে HP পাবে 2টো Lenovo পাবে আর 2টো HP তাহলে খালি খালি আছে ব্যাগ খালি আছে বলে কে নিয়েছে তার মানে কে নিয়েছে 4 জনের
বের করে রাখো, ওটা গরম হচ্ছে। 4টে টিভি, 4টে দুটোই ভাগ করা আছে, বাট একটাই লোড মানে করছে না। মেমোরি কার্ডটা দিয়ে দেবো। সুরেশকেও নিয়ে যান।
Hello.
Welcome you all back. I know this is still possible. We all are little bit things, so energizing to energize everyone. We have a very interesting topic of debate. We just start off. ठीक है? वाला बोलेगी बात अभी पहले डिबेट शुरू करें बोल देगी रे भाई
Debate.
हाँ बोल दे
Just the debate one. मुझे नहीं पता।
और उसका बोलना
इसको कैसे हटाऊं?
उसके बाद ये बोल देना ये सब कुछ अनाउंस करने के बाद सर लोग जब आएंगे अनाउंस इंटरेस्टिंग हो वी आर हैविंग ए लोकल साइट सीइंग टूर एट 6 PM sharp बस विल स्टार्ट एट 6 PM sharp फॉर द लोकल साइट सीइंग सो
कब आएंगे वो? After this all the debate and
हाँ तो
everything.
अभी अनाउंस करते हैं
अभी स्टार्टिंग में।
हाँ स्टार्टिंग में सबको ऊपर बुला लेना उसके बाद लास्ट में ये बोल देना ठीक है यार 6 PM sharp it will start those who are interested can join us ठीक है तो क्या एक तो वेलकम कॉल देम फॉर डिबेट स्टार्ट
Okay, all of these.
Good afternoon, everyone. Welcome back after the post-session lunch. I know everybody will be sleepy and the post-session lunch are always very exhausting, but please be cooperative and coordinative because we'll start with an interesting topic of debate, that is hospital management doctor or professional. And for the chairpersons for this debate is gonna be Dr. B.B. Karunamay and Dr. Jayant Kumar Acharya. Please welcome sir on the stage. Please put your hands together for both of them.
they are the chairpersons
I called them.
Please have a seat, sir. These both. For professional, the debate topics and would be held by Dr. Raj Ranjan Kumar sir, DSP Durgapur, and for Dr. Kushlendra Thakur, CMO Bhilai Steel Plant. Please welcome on the stage, sir. I would like to give an important notice that there will be in evening, there will be a visit tour of Durgapur side. So local sightseeing of Durgapur and at 6 PM. Please, everybody, please coordinate and cooperate because we'll be seeing all the sides of the Durgapur. If everybody is interested, please join us. Thank you. Now I please invite Dr. Rajaranjan Kumar sir on the stage.
चेंज यहाँ से होगा तो
चेंज होगा
बैक कहाँ से होगा बैक
चेंज बैक
ये Good afternoon to all, respected chairperson. My topic is hospital management by the professionals. Hospitals are complex organizations today, clinically, financially, legally and operationally. Doctor must lead the clinical decision only, and overall, hospital leadership should rest on the healthcare professionals. In India, we have complex enterprises and we have multi-crores budgets and the procurement process. HR management by doctors is very cumbersome, and it should be compliant with the NABH and NMC, CBC and CAG audits, labor law and biomedical waste rules, IT Acts and data privacy and cyber security. So these management competency are owned by the professionals, not by the medicals. Doctors are trained to save the life, not run the institutions. Doctors are engaged in diagnosis, treatment, procedure, research and teaching. Doctors are not trained in financial planning, cost control, supply chain, inventory management, HR conflict resolution, contract management, vendor negotiation and hospital economics. If doctors are forced to do the management of the hospital, it hampers the clinical excellence and clinical decisions, causes burnout of his skill, and result in ad hoc decision making. Already India is facing acute shortage of doctors. Can we afford to push them into the administration? No. Global and Indian best practices support the professional leadership to manage the hospitals. National health scheme, even in the international and national markets, all are managed by the professional managers, not the doctors. PSU like Excel, we are facing the problem of constraint of budget, resources are limited, and our accountability is very high. So, professionals should be engaged in improving the efficiency of the hospitals, optimization of the OT utilization and bed occupancy, and ensure the audit compliance. This result will be more money available for the patient care and better infrastructure without increasing the cost. If doctor manages the hospitals, it will cause conflict of interest. When doctor leads the hospital, there will be clinical biasness, departmental favoritisms, and difficult HR decisions. So, this is the process problem, so it will be managed by the professionals, not the medical. Professional improve the overcrowding, less waiting time, enhance the patient satisfaction, and reduce the violence against the doctors. Doctors are trained in diagnosis, treatment, clinical protocols, and medical ethics. But professionals are trained in hospital operations, finance, HR, and compliance and audit. So, professionals are ideal for the hospital management. I think doctors should not be forced into the management system because doctors are trained in medicines and professionals are trained in managing the hospital's processes. Thank you.
है यहाँ से नीचे होगा ना
या से होगा या से होगा नहीं चेक.
Good afternoon, everyone. Discussion topic is, should doctor lead hospital? Evidence-based argument. For me, the question is not whether doctor make good administrator, but whether the clinical excellence should be guided by clinical expertise or by the business principle alone. I am here to talk in favor of doctor head the hospital, for which I will give some example based on 2 decades of peer relevant research validated across the multiple healthcare system globally, are especially relevant to teaching and tertiary care hospitals. मैं जो भी कुछ भी अपनी बातें रखूंगा वो इन चीज़ों पर आधारित होगी, जैसे क्लिनिकल क्रेडिबिलिटी एंड पेशेंट आउटकम एटसेट्रा. वाई लीडरशिप एक्सपर्टाइज मैटर्स. हॉस्पिटल लीडरशिप डिसीजन directly impact patient care quality, diagnostic accuracy and treatment protocol because deep understanding of pathophysiology. अगर डॉक्टर लीड कर रहा है हॉस्पिटल तो वो डायग्नोसिस करने में, उसकी कॉम्प्लेक्सिटी को समझने में और क्वालिटी मैट्रिक्स के लिए वो जितना आगे रहेगा उतना एक प्रोफेशनल को आगे होने में मुश्किल जरूर होगी. The impact of patient safety, the mortality rate reduction, a study design comparison of 30 days acute myocardial infarction mortality rate, ऐसा देखा गया है कि physician led hospital में this is a 5.6% as compared to other leadership models में 7.6%, which is significant number. टॉप 100 यूएस हॉस्पिटल में एक एनालिसिस हुई, उसके 300 COs अक्रॉस द COs कैंसर, हार्ट एंड डाइजेस्टिव स्पेशलिस्ट शो अ स्ट्रॉन्ग पॉजिटिव एसोसिएशन बिटवीन फिजिशियन लीडरशिप एंड IHQ क्वालिटी पॉइंट्स. ये भी देखा गया कि फिजिशियन लेड हॉस्पिटल्स में 25% हायर क्वालिटी स्कोर्स मिला. IHQ मीन्स इंस्टीट्यूट फॉर हेल्थ केयर क्वालिटी. और ये भी पाया गया 8 to 9 एडिशनल IHQ क्वालिटी पॉइंट्स फिजिशियन लेड हॉस्पिटल में ज्यादा मिले. आप यहां तक भी देखेंगे कि टॉप 21 हॉस्पिटल्स जो अच्छे हॉस्पिटल माने जा रहे हैं उसमें 16 ऐसे हॉस्पिटल थे जो फिजिशियन लीड हॉस्पिटल थे. Doctors are trained in evidence-based medicine and critical appraisal of literatures. कब किस दवाई की सही में जरूरत है, मरीज की जिंदगी में क्या जरूरत होगी, वो समझने का काम डॉक्टर से बेहतर कभी भी कोई प्रोफेशनल नहीं कर सकता, क्योंकि वो पढ़ा ही वही चीजें हैं कि मरीज की जिंदगी के आगे सारे पैसे बेकार हैं. एक लाइफ भी अगर बच गई तो वो उसके लिए उतना इंपॉर्टेंट है जिसकी कोई कीमत नहीं हो सकती. क्रेडिबिलिटी विथ क्लिनिकल स्टाफ. अगर डॉक्टर लीडर है तो वो अपने स्टाफ के बीच में इतना अच्छा सर्वमान्य लीडर माना जाएगा जो एक प्रोफेशनल नहीं हो सकता, क्योंकि लीडर वो उन्हीं के बीच से उठ के आया है. वो उसको डे टू डे एक्टिविटीज की प्रॉब्लम भी मालूम है. अगर आप प्रॉब्लम लेके जाते हो तो वो उसका सलूशन इसलिए भी दे सकता है क्योंकि वो उन परिस्थितियों से गुजरा है. अगर एक वार्ड मैनेजमेंट करने के लिए आप कुछ मांगते हैं तो वो डॉक्टर चूंकि उन्हीं वार्ड से निकल के आया है तो वो जानता है. वो प्रोफेशनल पढ़ के नहीं आया है कि केवल प्रॉफिट इंड्यूस सोचे. उसको पता है कि वार्ड में क्या जरूरत है, मेरे डॉक्टर को क्या जरूरत है, मेरे सिस्टर को क्या जरूरत है, मेरे अटेंडेंट को क्या जरूरत है, मरीज को क्या जरूरत है. इतना, और वो कुछ भी चीज बोलेगा लोग उसकी बात बीइंग ए डॉक्टर आज भी ज्यादा सुनेंगे रादर देन एक प्रोफेशनल के. नया लड़का भी कोई इनोवेशन लेके आएगा तो हो सकता है डॉक्टर उसकी बात से कन्विंस हो जाए, वो लिटरेचर के हिसाब से, पर जरूरी नहीं कि प्रोफेशनल एक दूसरा जो निकला हुआ एमबीए है वो आपकी बात से कन्विंस हो सकता है उसको आपकी बात समझ भी नहीं आए और नए लड़के की बात उसे भी समझ में आए। एक एनालिसिस हुई है अबाउट 6,000 हॉस्पिटल यूजिंग, इसमें सारे डेटा जो एनालिसिस किए गए हैं उसमें हायर पेशेंट सेटिस्फैक्शन रेट उन्हीं हॉस्पिटल्स को मिला है जिसमें फिजिशियन लीड हैं, मतलब डॉक्टर लीड कर रहे हैं। पेशेंट टू पेशेंट पब्लिसिटी उन हॉस्पिटल की ज्यादा अच्छी है, उस जगह की ज्यादा अच्छी है जो फिजिशियन लीड कर रहे हैं, डॉक्टर्स लीड कर रहे हैं, उनकी रेपुटेशन ज्यादा अच्छी है। और सबसे बड़ी बात, फिजिशियन लीड हॉस्पिटल जो है वो एम्पैथी ड्रिवन एडमिनिस्ट्रेशन होता है। किसी चीज की जरूरत हॉस्पिटल को क्या सही में जरूरत है वो एक डॉक्टर से बेहतर प्रोफेशनल को बता पाना मुश्किल है। बीइंग ए ट्रॉमा सर्जन, अगर एक पेशेंट भी एक्सीडेंट का आता है तो अगर सीटी कराने की जरूरत है तो प्रोफेशनल ये पूछ सकता है कि अगर आप साल में 4 ही सीटी कराए, महीने में 2 ही कराए, तो मैं इतना पैसा करोड़ों रुपया कैसे निकालूंगा। पर वे डॉक्टर को पता है कि अगर एक लाइफ चली गई तो आप समझिए वो उसके लिए और उसके परिवार के लिए कितना नुकसान होगा, जिसकी भरपाई करना किसी के लिए भी बहुत मुश्किल होगा। डॉक्टर्स हमेशा आउटकम फोकस रहेगा, उसको पेशेंट के इंप्रूवमेंट की चिंता है, प्रॉफिट की उतनी चिंता नहीं है, वो लॉस भी सहेगा। अगर आपको सही में देखना है तो उनको देखिए, जब एक डॉक्टर पेशेंट ठीक होकर घर जाता है तो वो ज्यादा सेलिब्रेट करता है रादर देन कि पेशेंट अपने घर में सेलिब्रेट करे।
डॉक्टर ठाकुर, द टाइम इज ओवर।
बस एक सेकंड। प्राय ये देखा गया है कि आप ऐसे भी देख के देखिए कि जितने भी रेपुटेड क्लिनिक्स हैं, मायो क्लिनिक्स, अदर, सब फिजिशियन लेड हॉस्पिटल हैं। और हमारे यहाँ सेल में भी चूंकि पेशेंट्स हमारे ही लोग हैं, हमारे ही एम्प्लॉइज हैं, तो उनके प्रति जितना एम्पैथेटिक चीज डॉक्टर रखेगा ये दूसरा रखना पाना मुश्किल है। लास्ट में, अ हॉस्पिटल मिशन इज टू हील, इट्स लीडरशिप must reflect that mission. Clinical leadership must be foundation of hospital governance. Thank you.
Sir, any rebuttal by your part?
Future of Indian healthcare demands the professional leadership because India is moving towards digital health, telemedicine, AI, analytics, and insurance-driven care. So doctor cannot be expected to master the medicine plus technology plus law plus finance and simultaneously. So leadership must involve. My strong closing statement is doctors are heart of the hospitals and management professionals are its backbone. Indian health system does not need doctor managers or manager doctors. It needs doctors who heal the patient and professionals who manage working together for the patient. It will be the best for the hospital. Doctor understand the medicine, professional understand the system. So hospital need both of them.
सर ऐसा है कि हॉस्पिटल आप ऐसे भी सिनेरियो में देखिए तो डॉक्टर का ब्रेन किसी से कम नहीं, सबसे अच्छा ब्रेन डॉक्टर में है, उसके से सभी तकलीफ में रहते हैं। इस बात में कोई कंफ्यूजन नहीं है सर, हमारा ब्रेन सबसे अच्छा है, ये पहली चीज़। दूसरा, आप नियर बाई भी देखिए, अपोलो रेड्डी साहब चला रहे, AIG नागेश्वर रेड्डी चला रहे, मेदांता त्रेहान साहब चला रहे, और मेडिसिटी ये भी कर रहे हैं, ये क्या बोलना चाहिए अपना NHMMI अलग डॉक्टर्स चला रहे हैं। तो ये कुल मिला के ये मान के चलना कि डॉक्टर्स आर बेटर टू रन द हॉस्पिटल, नो डाउट, इसमें कोई कंफ्यूजन नहीं होना चाहिए। थैंक यू।
So very nice topic. What is the audience opinion? For doctors, how many?
Sir, before that opinion, can I just give a small comment?
Yes,
Here.
yes.
Quickly, not more than a minute here. Thank you. I think you talked about evidence-based medicine. Sir, सबसे बड़ा evidence ये है कि doctors who are running the hospitals as the heads, I think they have an MBA without actually having the degree. I think everyone will agree to that. You have done the same case studies, you have done the same courses, you have done the same management models. So I think this is something here that what we look forward to is the doctors at the helm. Just like you have different departments, even administration should be a department just like other clinical departments, and the head admin should be under your control as a doctor who is going to take the overall decision of that. So I think with this now we can take it forward. आप हाथ उठाइए जहाँ भी हाथ उठा. So all for the doctors.
Who need professionals? Only few.
Only Dr. Rajiv. Yeah, I can see, and Dr. Dr. Karmakar.
For me, for being a clinician for a long time, and then as a hospital administrator for last 3.5 years, I feel we should have some hybrid model. And also this education curriculum is going in that mode. The various institutes of our country are having post MBBS, post graduation, MD in hospital administration. One of the very nice example is AIMS New Delhi. I think per day 12 students take admission in the MD hospital administration after doctoral degree, after medical graduation, and the whole AIMS is being managed by that 100 peoples. So 36 3 years resident and 36 SR of the hospital administration. So each floor is being managed, each hospital area is being managed, the visitor control is being managed. There are around 60,000 of footfall per day in AIMS. But I think you have never witnessed any crowd there whenever you might have visited there. So at this juncture of higher end of different services, the other modalities of the regulations. So my view is to have the hybrid mode. Yes. So thank you all for very patient listening. This is a very good topic. Thank you.
Thank you so much for an interesting debate. Now we'll move ahead with felicitation. I invite Dr. S.S. Patil sir to felicitate Dr. B.B. Karunamay sir. Now, I would request Dr. Jayan sir to please come and I will start with the panel discussion. In today's digital age, social media has become an integral part of child's world, shaping how they learn, communicate, child's world shaping, perceive themselves. While it offers opportunities for education and connection, it also exposes children to risks such as addiction, cyberbullying, reduced attention span, mental health concerns. Understanding the impact of social media on a child's physical, emotional, and social development is therefore not a choice, but a responsibility. Today, we will briefly explore how social media influences children and what role parents, teachers, and healthcare professionals must play in guiding its safe and balanced use. Now, I would like to invite the speakers for panel discussion. Our first speaker is Dr. Dipti Prabha Ekka. Dr. Dipti Prabha Ekka completed her MBBS in 2009 and MS Ophthalmology in 2014 from SCB Medical College, Cuttack, Orissa. Presently working as senior consultant in SAIL Bokaro General Hospital since 2019. Awarded Best Paper in Community Ophthalmology in All India Ophthalmology Conference 2023. I would like to please give a huge round of applause for Dr. Dipti Prabha Ekka. Our second speaker is Dr. Biswajit Mondal, additional CMO in SAIL ISP Burnpur, MBBS 1998 in SAIL ISP from Arjikar Medical College, Kolkata, and MD in Psychiatry 2003, Kanke CIP, Ranchi. Joined as psychiatrist at Burnpur Hospital, SAIL ISP, 2006, 20 years of a long service. I would like to please invite Dr. Biswajit Mondal. Please give a huge round of applause for Dr. Biswajit Mondal. Our third speaker would be Dr. Shubhasmita Patnaik, working as senior consultant and faculty in Department of Pediatrics and Bhilai. Pursued MBBS from MKCG Medical College, Brahmapur, Orissa in 2010. Post-graduation in Pediatrics from Sardar Vallabhbhai Patel PG Institute of Pediatrics under SCB Medical College, Orissa in 2016. I would like to call Dr. Patnaik with a huge round of applause. Please welcome her. I would like to invite all the chairpersons for this session, that are the moderators for this session are Dr. Mahesh Kumar, DCMO Durgapur Steel Plant, and Dr. Rajiv Kumar, Sir, Assistant CMO Durgapur Steel Plant. Please give a huge round of applause for Dr. Mahesh and Dr. Rajiv. We would start the session now. Our first speaker for the session is Dr. Dipti Prabha Ekka.
Wait. Good afternoon to you all. Post-lunch session a bit, there is a tiring, after post-lunch session it is a sleepy environment, but our respected panelists are in very cheering mood. So we must recognize their smiling faces now, and they are going to deal with such a nice topic of child and social media. Regarding social media, way back in 2004, the Facebook was introduced. Later on, Reddit, TikTok, Instagram, so on and so forth. There were so many social medias platform. So, especially in the corona era, I think that the dependency becomes much more evident after the child and adolescent group was residing in their home. And subsequently, this dependency created a special psychiatric disturbance to them, which is called substance use disorders. And all of the substance use disorders features, then those features are then attached to their daily to daily life. And those substance use or substance addicting behavior disorders had created so many things. For example, behavioral issues, then addictive issues, then physical issues. And the experts are here to describe other issues related to their respective faculty and fields. Now I'm handing over this mic to our main moderator, who is a psychiatrist also, Dr. Mahesh Kumar sir, to handle the session further. Dr. Mahesh Kumar.
Good afternoon, everyone. I am feeling highly privileged and honored to welcome you all in today's panel discussion over the topic child and social media, which is highly relevant in current scenario, especially since COVID period. As we know, social media is the integral part of everybody's life, especially children, that determines how they learn, communicate, and see the world around them. It offers many positive opportunities to the child, as well as it also challenges the parents, teachers, and community that must be thoughtfully addressed. We are fortunate enough that we have three eminent speakers from different specialties to discuss over the various aspects of social media. I am hopeful that it will be helpful enough for for child, how they navigate the social media safely and safely. Thank you. Now I will call Dr. Dipti Prabha Ekka, eye specialist from Bokaro General Hospital, to deliver her presentation.
Thank you, sir. Good afternoon, everyone. Respected chairperson and the esteemed audience, I am Dr. Dipti, and I will be speaking on child and social media, and I will be covering the eye aspect. Coming to the a study done by various countries, the average time spent by a child in various countries ranges from 50 minutes to as high as 250 minutes. The effect of such a long screen time on eyes can be broadly divided into short-term effects and long-term effects. The various symptoms of short-term effects are eye strain, irritation, pain, tired eyes, blurred vision, headache, dry eyes and watery eyes. Long-term effects is the myopia, which I will be discussing in detail in the subsequent slides. The majority of the effects are because of the dry eye, and why there is dry eye in long screen time is because of the decreased blink rate. When there is decreased blink rate, there is meibomian gland dysfunction. What does this meibomian gland do? It secretes the mucin layer of the tear film. Since this is hampered, the tear film is hampered, and this in turn leads to dry eye. The various common symptoms of dry eye are stinging, burning, redness and episodes of blurred vision. Then there is something called convergence insufficiency. That means when the eyes are not properly converged, we experience a halo effect and a blurring of vision. Now coming to the main topic of my interest, that is myopia, which is now hailed as the next epidemic after COVID. It is surprising to know that by 2050, 50% of the world population are going to turn myopic. So the big question is that in the Charles Darwin theory of evolution, is it that the next evolution would be the man with the specs? And before such a thing becomes a reality, we should know what is myopia. Myopia or nearsightedness means when the rays of light, instead of converging on the focal point of the eye, converge in front of the focal point. Now let us know, why does increased screen time lead to the development and progression of myopia? When we are focusing on object from a near distance, the eye, there is a continuous signal, and the eyeball, in order to focus it on the retina, it elongates. Consequently, this stretched eyeball becomes permanent, and this is the main physical cause of myopia. And there is, when we are focusing on something from the near distance, there is a mechanism, the mechanism of accommodation. Here what happens, there is ciliary muscle contraction, relaxation of the suspensory ligament, lens become more convex, increase in the dioptric power of the eye, and near object is focused on the retina. So this is what happens normally, physiologically. Now imagine that this mechanism occurs for a longer period of time, and so there is increased accommodative demand. That means the ciliary muscles are working for a prolonged time. So gradually what will happen? They will become fatigued. It is similar to somebody is running for a longer period. What will happen? The leg muscles will get fatigued. Or if we are holding something for a longer period, the arm muscles will get fatigued. Similarly, when we are looking at a screen for a longer time, the ciliary muscle gets fatigued. And so the accommodation is hampered, and there is accommodation, reflex is lost, leading to the blurring of vision. The third most important thing is that when the child, instead of playing outside, is looking at the screen time, there is something called outdoor time trade-off. That is, he is trading his outdoor time with his screen time. So two things happen. The dopamine release, which is responsible for the inhibitory signals to the retina, is hampered, and the distance focus is lost. There is a very important study. One meta-analysis found that for every 1 extra hour of daily screen time increases the risk of myopia for about 21%. The most critical age is 10 years when the eyes are at the peak stage of development. Along with myopia comes a host of very potentially vision-threatening diseases such as myopic maculopathy, retinal detachment, posterior subcapsular cataract, and glaucoma. So coming to the remedy, first coming to primordial prevention, many countries such as Nepal and Australia have banned social media for children less than 16 years. The International Myopia Association recommends no more than 2 to 4 hours of screen time for children according to the age of the child. Now let us look what are some evidence-based lifestyle changes we can do to prevent the progression of myopia. First is the green time mandate. We have already discussed the dopamine in the retina is a neurotransmitter that inhibits the eye from growing too long. So the International Myopia Institute recommends 80 to 120 minutes of outdoor time per day. Second is something called the 20-20-20 rule. That is, for every 20 minutes, take a break of 20 seconds and look at a distance object for 20, which is at 20 feet away. What it does, it relaxes the ciliary muscle, which is responsible for accommodation. And one should remember that we should blink fully during the break. Now we have some advanced medical intervention for myopia control. First is we have the low dose atropine eye drops, which acts on the receptors on eye to chemically signal the eye for abnormal elongation. Secondly, now we have the next gen spectacle lenses such as the DIMS, deep focus incorporate multiple segments, and Hall, highly asymmetrical lenslets. What these do, they have a tiny micro lenses. They in the center of the glasses, which create a protective defocus zone. The defocus zone acts as an inhibitory signal for the retina against abnormal elongation. So I'll conclude by saying less screen time for healthier eyes. Look up and see more. Thank you.
Very good. Yes, Dr. Ekka, I want to know from you, is the myopia reversible by any means?
Yes, sir. This is the most common question that we get in our OPD when the child's parents, they ask, when we say them, your child has a myopia. So myopia is not reversible because the eyeball is going to elongate. Okay, so the myopia is going on, it will go on progress till the age of 23 to 24 years. Then the myopia is going to stabilize when the growth of the eyeball stabilizes. After that, if the child wants to remove his glasses, we have surgeries such as LASIK, we have Intacs, but the myopia is not going to reverse. The drugs are also, they can halt the progression. If per year, if the child is getting -2 more, that we can halt by lesser screen time, by outdoor activities, and by atropine drugs. But totally, if it comes, the glasses will be removed. That is not a reality.
Okay. Are the anti-glare glasses are going to help anymore?
Sir, anti-glare glasses, I think they are the marketing gimmick. Okay, all the tearing and headache, they occur due to the accommodation demand. The anti-glare glasses, they will just cut down the glare from the screen time. But if the child is using screen time for more, then also he'll have accommodation demand is more only. Then also he'll have headache only. The headache, tearing and watering is not going to go away. So that's basically a marketing gimmick.
Okay. Thank you. Thank you, Dr. Ekka, for your comprehensive and enlightening presentation. Next speaker is Dr. Subhas Mehta from Bhilai Steel Plant Hospital. Subhas Mehta. Child specialist from Bhilai Steel Plant Hospital. Subhas Mehta.
Respected HOMs and dignitaries, good afternoon to everyone. I am Dr. Subhashmita, and I will be talking from perspective of a pediatrician. So whenever you think of the term social, it is always associated with tangibility or being physically present or the warmth of proximity. For the first generation we are witnessing, who are growing under the influence of digital media, for them, they are learning a new form of togetherness. They are visible without being physically present, they are connected without being close, and they are surrounded by many, but actually alone in their real life. So before debating that social media is good or bad, in this session we will explore that how the risk and benefits coexist and how the responsibility of the caregiver reshaped the conclusion. If you see the timeline, 2005 was the first year where a child-friendly platform was started that became popular, that is Club Penguin. And in mere 20 years, now the child's digital media is full of algorithm-driven feeds. Seeing the statistics, 82.2% know how to use a smartphone, 76% know how to use it for social media, but only 50% know how to blog or report or make their profile private. That means the children are using social media, but they are not yet prepared for that. Again, another study shows that the average time spent on social media by children is 3 hours, and 24% are problematic internet users. YouTube, WhatsApp, Instagram being the most popular platforms, the user rate is around 71%, ranging to 93%. A study in India between 12 to 17 years showed a sharp upward trajectory in last 5 years, particularly in the COVID and post-COVID era, with a projected user rate of 81% in 2025. If you dissect age-wise, 76% prevalence in 13 to 17 years, 52% in 9 to 12, and 42% in 6 to 8 years. So why we are seriously talking about this? As clinicians, you know that the human brain is a masterpiece of neuroplasticity. Experiences shape which neuronal connection are to be kept or to be lost. If a child's primary stimulus is this rapid-fire digital content which is impulsing dopamine to his blood, then definitely we are risking pruning of the synapses which are meant for deep sustained focus or the empathetic behavior. And this is definitely going to influence the cognitive or the logical thinking of the early brain. Again, when the child grows, the fear of missing out, what we call FOMO, is keeping their HPA axis in chronic activation, leading to high cortisol level. But if you guide them properly, it can definitely boost their creative potential and uplift their skill. It can make connection. It can give them. It can help them in identity affirmation. They can join a support group. They can share their ideas in international platform. They can get exposed to new culture, pursue new hobbies, and get an identity. But why we are fearing? Because of lack of filter. In younger children, they are exposed to unsuitable videos and games, overstimulation. These are leading to behavioral defect like virtual autism. In older children, early exposure to mature themes like sexual content or extreme violence, peer confluence, rising cyberbullying, these are causing emotional harms. Again, they do not know how to protect their data or personal information. This is leading to data breaches and legal issues further. If you talk about the physical part, sedentary behavior and sleep disruption, these are leading to early lifestyle diseases. Now talking about the psychological effect, digital media is curating a fake persona rather than developing a self. How the peer connection, they are quantified by how many likes or followers you have. So they are always in the want of a digital validation. If they are lacking this, they are either becoming aggressive or they are isolating themselves and going into depression. Another part is cyber victimization. So where can we stop? On platform level, there should be parental consent workflows, youth privacy by design, moderation, and rapid takedown process of the reported content. For parents, IAP says no screen time below 2 years, 2 to 5, 30 minutes, more than 5, balance the use. Know the red flags: excessive use, tantrums in early childhood, withdrawal, sleep disruption, secretive use, mood changes, cyberbullying in older children. Now this is an important slide for parents. Set clear screen time limits, use parental control, do not spy on them, monitor the online activity gently, encourage open communication with them. Parents should model balanced digital behavior themselves, and there should be device-free family time, promote offline activities, teach privacy, consent, critical thinking, and balance supervision with trust building. For schools, Pragyata is an 8-step digital teaching framework by Ministry of Education to balance the offline and online education by 8 steps. That is plan, review, arrange, guide, talk, assign, track, and appreciate. So what can family and schools teach to children? Critical thinking to evaluate the online content and spot misinformation, privacy skills to protect the personal information, respectful behavior like online etiquettes, consent and anti-bullying attitude, and responsible sharing before sharing their personal content. Now comes the role of healthcare providers and pediatrician. They should always screen in normal visits for all the children regarding the red flags and excessive use. They should guide them regarding the age-appropriate limits, device-free sleep. They should include the caregivers and families in this counseling, coordinate with the schools and NGOs to raise awareness. They should intervene early, can give the standard reference guidelines to them, and monitor and follow up. These are the laws in India, that is at the policymaker level, DPTP Act, IT Section Act, and NCPSR guideline to protect the children from the harmful content. Now this is the final slide, that in this digital era, you cannot keep your child digitally blind. It is impractical. So if you use it properly and constructively, it is always a win-win situation. So parents, they should monitor the screen time, teach privacy setting, and encourage regular offline activity. Schools also do the same and stick to Pragyata guideline. Clinicians should early screen and early intervene and also educate. Platforms should abide by the law, and policymakers should enforce the law. These are the references, and thank you for the patient listening.
Thank you, Dr. Subhasmita. Very nice presentation. Madam, how will you screen the child in busy clinical setup without extending the consultation time?
Sir, actually there is no particular standard screening tools till now. But in adolescent, when we assess adolescent, there is a HEDES screening is there that used for home use, education, activities, drugs, then suicide. So we can add social media. And in other parameters of HEDES also, we can see that home use, any triggering factor that is allowing the child to use social media. Again, in education, declining academics, we can see. Then any other risky activity which is the child is indulging. So this is the basic one. On another, American Academy of Pediatrics uses another scale that is called 5C, that is child, how is the child's personality, content, what content the child is watching, calm, that whether the child is using the social media to calm himself. Then another is crowding out, that whether he is deferring other his routine activity for social media. Okay, so these are the basic scales. After that, some extra scales are there, like social media disorder scale, other scales are there.
Okay, how will you explain neuroplasticity to the parents in a simple form?
Sir, if you say in local language, we can say that actually, जब बच्चा, I'll talk in Hindi because we are talking to parents. So हम बोल सकते हैं कि जब बच्चा पैदा होता है तो उसके नसें जो है वो बहुत घने होते हैं और बहुत सारी नसें होती हैं क्योंकि उसका ब्रेन बहुत अच्छा ग्रो करता है 2 साल तक. तो वो उसका जो ब्रेन है उसके ऊपर डिपेंड करता है कि वो पहले 2 साल में वो क्या अपने इस्तेमाल में लाता है. तो अगर आपका बच्चा मोबाइल देखता है या टीवी देखता है तो वो जो चीज़ें हैं वो सडन उसको खुशी देती है. तो उसकी जो आदत रहेगी, जो नसें हैं जो उसको खुशी क्या बोलेंगे उसको रैपिड ग्रेटिफिकेशन जिसको देती है, वो नसें उसके हमेशा स्ट्रॉन्ग होते जाएंगे. और जो पढ़ाई वाले हैं या जो भी अच्छे बिहेवियर वाले हैं तो वो नसें जो है वो धीरे धीरे वो मिटता जाएगा. सो आगे जाके उसको ये इशू होगी. तो दिस आर द सिंपल वर्ड्स वी कैन यूज.
Thank you, Dr. Subhasmita, for your informative and enlightening presentation. Now I will call the senior psychiatrist, Dr. Vijit Mandal sir from ISCO Burnpur.
Good afternoon, respected moderators, heads of medical, delegates, and parents. I'm Dr. Vishwajit Mandal. I will be covering the topic as from the psychiatrist point of view. Social media, we all love it, we hate it. It's good, it's bad, it's there to stay. Children and adolescents have grown up with social media, and so we are. And social media refers to the means of interactions among people in which they create, share, exchange information and ideas in virtual communities and networks. This is the study of American Psychiatric Association, which shows that the 38% of respondents says about harmful effects, and positive effects give a response given by only 5%, and 12% respondents were unsure. But most of the people, 45%, they gave response as both positive and negative effects on mental health. So most of the people are considering a balanced approach. This is the bar diagram. Majority of the countries supporting the social media ban for children under the 14 years of age. So this is the picture reference, difference from the 2024, average around 71%, India having 68% a reduction compared to last year. Not everything is bad about social media for children. So what are those benefits for the kids? It enhances communication skills, platform to spread awareness and wellspring of information. It is source of pool of unlimited ideas. It helps to become a tech whiz, platform of expression. It helps networking with friends and family, and it helps in engaging subject matter learning. Digital competence and social integration. Spending time online is important for the younger generation to pick up the necessary technical skill they will need to navigate through their future life, and it allows them to be competent citizens in digital age where they can fully participate in the broader society. Peer-based learning dynamics. It has introduced a more peer-based learning method. They are always interacting with giving feedback to one another, which refines their learning process, and they are also more enthusiastic to learn from each other rather than from adults, teachers, or parents. Social connectivity beyond communication, not only in the social media tool for communicate, but also an important part of the lives of adolescents and young adults. It gives them an avenue to stay connected with their peers from sports teams, activity clubs, and classes having similar interests. Enhancing empathy and relationships. It has been observed that social media makes people more empathetic, considerate, and relationship oriented. They express how they feel, they communicate, comment on their liking of pictures, videos, and status updates posted by their friends. Community engagement activism. Kids also get to have an influence on their community through social networking groups and help bring about positive changes in the society. They participate in fundraising campaigns and political events, and also participate in debates. Empowerment and social confidence. Social media gives introverted kids the chance to open up to the over internet, giving them a boost of confidence, and many youngsters find it easier to talk to people after interaction with them over the social media platforms. What are the negative effects on child? These are the three main areas: cyberbullying, online predation, and social media addiction. They are interconnected. Mostly problem comes over body image concerns. Too much time on social media apps lead to increase in body dissatisfaction, eating disorders, low self-esteem, and 46% of teens of 13 to 17 years of old said social media made them feel worse about their bodies. Cyberbullying on internet and social media to harass, threaten, and embarrass someone is common, and harmful language, images, and videos are prevalent. 64% of teens reporting they are often sometimes exposed to the hate-based content. Devastating results from trying dangerous viral trends following blindly. What happens? They also often get arrested, and often they need to be hospitalized, or even there is death, incidents of death. Kids don't have the cognitive maturity and executive functioning to think through harmful situations and why those might be a bad idea. Sometimes they are placing themselves in the physical risk. Online predators. There are people also on social media who target children and teens, whether they sexually exploit them, financially extort them, and sell them illicit manufactured drugs. Nearly 6 out of 10 teen girls says they have been contacted through social media platforms by a stranger in a way that makes them feel uncomfortable. most commonly productivity drain and academic consequences. Youngsters addicted to social media end up spending hours each day watching videos, photos, and other content posted in their accounts they follow. The addiction disrupts their activities such as schoolwork, sports, study, and other productive routines, resulting in poor grades in school and subsequently low mood, leading to depression. Detrimental effects on mental health. Studies suggest that children spending more than 3 hours a day on social media twice are likely to suffer poor mental health. Their immersion in virtual world delays their emotional and social development. Narcissism and self-obsession. Obsession with the self or posting endless updates on selfies on social media increases narcissism in youngsters. Their mood depends heavily on how they are appreciated on their photos on social media. They go into anxiety and then don't get attention they expect. There is precursor of dysfunctional emotional conditions later in their life and lack of empathy for others. Harmful content, offensive, explicit, violent contents are easily accessible on the internet and they impact on the young minds. And social media safety for a child, like what the parents have to do, that has been depicted. And around 33% of girls, all between 11 to 15 years old, feel addicted to social media. More than half of the teens say it is hard to give up social media, and the FOMO is real, that is fear of missing out. Changes in daily behavior, there is increased irritability, increased anxiety, depression, disturbed sleep, low self-esteem, and lack of focus and concentration. What are to be done by the parents? Talk to your kids first. Discuss with them about the problems, how to handle them, limit screen time, set a limit, or take help from some apps, monitor their usage, what they are using and how judiciously they are using. Model good behavior. It's easier to say than done, but you have to behave accordingly so that child can follow if they find a role model in parents. The good thing about the social media is it gives everyone a voice, but the bad thing, it gives everyone a voice. In social media impact, individual and society scale, all the 4 quadrants, we need to stay at the upper right quadrant where there will be enriching of society and individual development. These are the advantages and disadvantages have been enumerated. Anyone can publish their thoughts online. It's free source of information. It can help make friends, allows for dissent, and allows truth to get out. And it's an educational tool. And disadvantages, it can lead addiction, increases online bullying. It lead to body image issues, spread misinformation, always sleeplessness, and increases stress. In conclusion, social media can lead a useful tool interaction, learning, communication, and entertainment. Misuse or excessive use of social media can lead to negative consequences such as cyberbullying, anxiety, and health problems. Parents should supervise their child's use of social media before adolescence and avoid adverse effects. Excessive time spent on social media can lead to addiction and hinder their development of interpersonal relationship. Initiating a healthy conversation with your child can assure them that parental involvement is for their safety, not an invasion into their privacy. So, children already using social media, the decision to be taken, how to maintain a balance so that they can tide over the crisis, they can find a suitable way to battle in troubled weather. That is all. With these words, I thank you all for your patient hearing. Thank you.
Thank you, sir. Thank you very much for your good presentation. Sir, due to lack of time, I have just one question, sir. Sir, what will you suggest the parents whose child is dependent on social media?
First of all, we need to talk to the children, what they are thinking, how they are using, whether they are using judiciously or optimal using is not, set a limit, whether they are maintaining a balance in their life in addition to their daily school life, or playing, whether they are going for outdoor activities or not, interacting with friends physically, not necessarily online or every time there will be online. So these are the ways to manage children by the parents.
Thank you, sir. Okay. All the speakers have presented very nice with good information and knowledge sharing. Now the discussion is open for house. Now the house is open for discussion. Just 2 questions is invited from the house because we are already running late.
is it by Topcon? Sorry, sir, I don't have any. Topcon, there are two. First, though, there's the new age of glasses, and secondly, now they have coming up with the red light. That is also they are doing ongoing studies that hold the. Yes, I think that must be in the studies. There are two. These are the most which have been shown effective till now.
Thank you. Thank you. Thank you.
It was an interesting and amazing panel discussion. Thank you so much, everyone. Now I would like to invite Dr. Ajit for the panel discussion to felicitate all the moderators as well as the speakers. We would begin with Dr. Dipti Prabha. Second speaker would be Dr. Biswajit. Now the third speaker would be Dr. Patnaik. And to our moderators, beginning with Dr. Mahesh. Dr. Rajiv. Thank you so much, everyone. He is not only a master surgeon, but a mentor, a reformer, and inspiration to generations. Ladies and gentlemen, please join me in welcoming the Architect of Excellence, Dr. Satyajit Bose. Please give a huge round of applause for Dr. Satyajit Bose.
Should I speak or just sit?
Yes, sir, please. I would like you to please say some few words.
Dear colleagues, I would just like to tell you that whenever I go to a conference, I always see 4 or 5 categories of doctors. Number one are the real serious guys like you who really sit up post-lunch and listen to lectures. That is grade 1. Grade 2 are the guys who will go to the lecture hall, listening to lectures, and then moment the light becomes dark, they will go off to sleep. Grade 3 is people who register themselves but don't enter the hall. They go to the stalls, collecting stuff here and there. They are called stalwarts. Grade 4 are the people who register themselves. They come to the auditorium, come to the venue, but they remain outside. They are called outstanding doctors. And the 5th and the best category doctors are they register themselves, they come to the city, but they don't enter the venue, they go out exploring the city. They are called autorome. So we got 5 categories of doctors. Yes? Huh? Bolo. So they are autorome modes actually, basically a sub-classification of autorome. But yeah, just to wake you guys up and talking this thing. But here, I just want to tell you, there's a lot of speakers here, I will not take much time, but our medical profession is undergoing a radical disruption. Gone are those days when we will look at take a stethoscope and listen to the heart and first heart sound loud, mid-diastolic rumbling murmur, or go and listen to the PS. Nobody does nowadays. They just send the patient to the echo machine or the ultrasound or do something. But what is important is that clinical medicine must not be forgotten. There is a lot of automation, there is a lot of AI coming into it, there are a lot of logistic things which are replaced by various software mechanisms and all that. And the brightest kid that has now come in the market is the robot. We at the Mission Hospital, we always try to stay ahead of times, and we have acquired the robotic machine, robotic assistant that is called the Da Vinci Xi, which is one of the best robots in the world and only one of its kind in South Bengal. The only one, other one that is there in another hospital, they have not purchased it in Calcutta. They have kept it on a pay-per-use basis. But we have actually done and taken it. And Dr. Arnav Chakravarti, Dr. Ashish Krishna, and all the rest of the doctors, robotic surgeons are actually performing. And there are days coming when there will be tele-robot surgery, in which surgeon will be sitting at some other site, maybe in Timbuktu, and he and the assistant will be in the operation theatre, and he will be able to do stuff. There has been instances like this where angioplasty has been performed in a hospital in Ahmedabad, and but for surgery it will take some more time. I mean, these are the days of sci-fi, and I wish you all the best, all my steel doctors. You know, I am part of the steel fraternity as well, between you and us. So thank you very much for giving me this opportunity to be here. Thank you, Ajit, and everybody in the steel fraternity.
Thank you so much, sir, for such an inspirational speech. I would like to invite Dr. Vinita to facilitate Dr. Satyajit Bose. Now I would like to invite all the guest speakers for this session. Is Dr. Arnav represents the perfect blend of surgical precision, academic brilliance and compassionate cancer care. Please join me in welcoming Dr. Arnav Chakrabarti. He is an associate consultant robotic oncosurgeon, Mission Hospital, Durgapur. Please give a huge round of applause for Dr. Arnav Chakrabarti. The second speaker for this session will be Dr. Ashish Krishna, sir. He's a consultant general laparoscopic obesity and GI surgeon, robotic surgeon at the Mission Hospital, Durgapur. For this session, guest speakers, the chairperson will be Dr. Vinita Singh, GMMS, Tata Steel Limited, and Dr. Kaushlendra Thakur, CMO, Bilai Steel Plant. I would please invite both of them on the stage. Please give a huge round of applause for doctors. I would request to begin the session. Dr. Arnav, sir, please start the session. Thank you.
Thank you, chairpersons, my senior colleagues. So, robotic cancer surgery. Now, it has come to stay. Previously, 80s were of open surgeries. Early 2000 went to laparoscopy. Now, and the near future definitely belongs to the robotic surgery. So here I am. I came back from Rajiv Gandhi Cancer Institute, Delhi, after completing my surgical oncology and robotic training program, and I've joined Mission Hospital. So, my topic today is advanced robotic cancer surgery. Is focus shifting beyond the metro cities? Is the focus right now on the tier 2 cities? That is my talk of the day. So, here I am doing the first robotic surgery using Da Vinci. It was a colon cancer surgery done in Durgapur for the first time, 20th June 2025. So, what if I tell you, see, this is an organ. Previously, we used to think that human hands can't reach up to this level. But using robotic arm, can you identify the place where the surgery is being done? So you can see the endotracheal tube, right? This is the posterior tonsillar pillar, and I am operating into the pharyngeal mucosa, in the lateral pharyngeal wall. There is a small tumor, 1.5 centimeter in size. Previously, we used to give only radiation, and the survival benefit was not much there. With using small, slender robotic hands, I can actually be there, cut it out, and the patient is going to have a survival of nearly more than 95%. So this is called transoral robotic surgery or TORS. Now the next thing, scarless robotic surgery of thyroid. Previously we used to make an incision over the neck. Now in the coming days, after the robot was instituted, we started doing thyroid cancer surgery using 4 or 5 ports in the chest region. So if you can see, this is the position of the ports, the black areas. Now we have put the robot in such a manner that it goes inside the thoracic wall, then goes into the neck, and right now see these are the port positions. And using these ports, the robot is installed in such a way that we are going to do the thyroid cancer surgery from the thorax, just above the nipple area or the axillary area. 4 cuts will be made, but those are hidden scars. So very beautifully you can see the recurrent laryngeal nerve here. See, this is the recurrent laryngeal nerve, which are the dreaded complications of recurrent laryngeal nerve injury. We can see using a robot is just a piece of cake, and in cancer surgery also RLN injury chances have gone down using a robot to less than 0.1%. So it was a modified Baba approach. Now, what happens during a robot assisted surgery? In early 2000, first robotic Da Vinci system was installed in US. It came in 2015 in India, and robotic Da Vinci XI, the latest in Indian market, we have got in our mission hospital in last year only. I'm happy to share that I, along with all our colleagues, and thanks to Dr. Satyajit Bose, in last 8 months we have completed more than 120 surgeries. So how actually the robotic system works? So see, there, in the OT, in the operation theater, it has 3 parts. A robot has 3 parts. First is on the left, a surgeon sits with a camera, a desk and chair like thing with an advanced laptop like thing in front of him, and he does some movements in the laptop which is going to get reproduced in the second patient side cart. You can see there are 4 arms in the patient cart. The patient is lying on the table, and these 4 arms of the robot is actually going to get inside the patient and does the surgery. Whatever I am doing in the laptop, my hand movements are going to replicate it in that patient cart. And third is obviously a monitor. So this is a surgeon's console. It is just a car-like thing where I have my 2 hands, 2 fingers, the thumb and the middle finger, and the right index finger for the clutch. Below down, this blue and yellow switches are for my coagulation, like in coagulation cautery we use. And the left side, we are having this clutch, foot clutch, and the camera. So this is the patient cart I have already talked. There is a small tower-like thing, and 4 arms are coming down from the robot. Now, what is actually being done? Like in laparoscopy, we see we have to do 4 ports in laparoscopy, 3 or 4 ports. We do the same in robotic surgery. These ports are going to get attached with the arms of the robot. This is called docking. How it is done? See, the ports have already been made over the patient's abdomen. Now what we have to do is to attach these 4 arms into these ports over the abdomen. The single most advantage of Da Vinci XI system is this docking takes place within 1 minute. In other robotic systems, this usually takes 30 to 90 minutes depending on whatever robot we are using. So 30 to 90 minutes in other robots, and Da Vinci in Mission Hospital, we're doing in less than 1 minute of time. So less operating time, the cost is going to get down. So second is, if this is centering, I'm not going into the details of this. So the options are open, traditional laparoscopy, Da Vinci robot assisted surgery. Now why to choose robot assisted surgery? See, there are multiple talks over that, multiple debates. 2 basic things I'm going to talk about. First is, patient with robot assisted surgeries, seriously, they experience much lesser pain. If you tell me one difference between laparoscopy and robotic surgery, this is going to be the pain. even after laparoscopic surgery, whenever the patient comes at the first visit after 7 days from the OT, they usually have some kind of pain. But using this robot, we have seen after 7 days, whenever we are, the patient is going to, is coming back, you can't just you can't recognize this patient, whether or not she or he has gone for an operation. So why does the pain is less? So see, this is how the robot moves. So the fulcrum is actually on the organ. Whereas in laparoscopy, the fulcrum is on the skin. So the skin, holes over the skin in laparoscopy are going to get stretched, and that is causing pain. This is not there in robotic surgery, specifically Da Vinci. Now superior 3D magnified visualization, this you all know in a robot. So very beautifully you can see while doing, many of you have done or seen hysterectomy. You can see superior magnified vision. This thing I am watching in a camera, in my eyes. This is the beauty of the robotic surgery. See how beautiful the things, the anatomy are going to get cleared. There was a left ovarian mass, and we are doing a total radical hysterectomy for this patient. Third, this was a video of endometriosis. In complex endometriosis, grade 3 endometriosis, robotic assisted cancer surgeries are doing wonder, and we are clearing each and every bit of endometriotic tissue using this robotic technology. Third is suturing. Laparoscopic suturing, it is cumbersome, but robotic suturing, I will tell you, is a piece of cake, because the hands move like the wrist, and even after that, human hands have at least 5 degrees of freedom. Robot in Da Vinci specifically, they can actually entertain you with 7 degrees of freedom with an extra joint. If human hands has wrist, finger joints, elbow, shoulder, robotic can reach up to a last joint, the cervical joint. So 5 level of joints are there in robot, one more than the human hands. So this was the basic robotic thing. What we have incorporated into robotic surgery is currently, and this is a thing of future, this is an ICG, fluorescence imaging and augmented reality. This is going to come up in Da Vinci Xi very near future. So using this, we can do perfect anastomosis. We can actually identify small cancerous tissues also, and we are going to remove it out. So this is obviously what I told you, that 7 degrees of freedom. This is an ovarian cystectomy operation. See how beautifully the cyst is going to get separated from the ovary. So the ovarian wall is on the left, and the cyst is going to get separated just with a push of this robotic arms. And this is a Caesar, by the way. So again, this suturing, whatever. So benefits of robotics in oncosurgery is a better clinical outcomes. Why? Because there is less blood loss, less pain, no blood requirement until unless it is less than 7. More than 7, we are using 1 blood, but less than 7, we are using 1 blood. More than 7, no absolute blood loss. So no blood requirement is there. So, so this was the first procedure we have done in June 2025. Since then, 120 surgeries have been completed in our hospitals in surgical oncology, gynecology, general surgery, all the departments together. So I was also the part of this SSI Mantra team when they did the validation study in Rajiv Gandhi, Delhi. So now comes the second part, the actual part, Tier 2 cities. This is, if someone can search this, robotic surgery in Indian Tier 2 city. Durgapur has come up in Google whenever you search in India Tier 2 robotic cancer surgery. So this is just after we did 50 surgeries. This has come up in November last year. So Durgapur right now is in the map of robotic surgery. Why should people choose robotic cancer surgery in Tier 2 cities in Durgapur? I'll not take much time, but there are major reasons for it. Why a person who is suffering from cancer should get operated in Durgapur or Tier 2 cities and not move to Apollo, Chennai, Hyderabad, Bangalore. First, massive cost savings. Let me tell you one thing. Last week we did a robotic surgery in Apollo Chennai, the cost was in nephrectomy, it was 8.75 lakhs, and we did it for 3.9 lakhs. So this is lower procedure cost, more than 50%. Indigenous robot at service, the best in the world, is now at Durgapur Mission Hospital. सबसे important है lower hidden cost. First, you move to a city for treatment, you take 3 person along, so the travel, the food, the stay are going to get costlier. Second important, enhanced personal care. Homely environment घर के पास हो रहा है with less stress, घर वाले देखने आ पा रहे हैं. More personal attention with dedicated one-on-one time with surgeon, and recovery near home with follow-up. Follow-up is very, very important thing in cancer, like the treatment itself. So follow-up करने के लिए बार-बार आपको जाना पड़ता है. आप टाटा से ट्रीटमेंट करवा के आए मुंबई से, आपको बार-बार जाना पड़ेगा. And this has to continue lifetime. उतना टाइम नहीं है किसी के पास. Come here, Durgapur. We are going to give same options and in your homely atmosphere. Third is equivalent clinical standard, expert migration. So the people like me who were studying DM, MCH and super specialties and robotic surgeries are now going to come up to tier 2 cities, because we want a good work-life balance and a quality work. Modern infrastructure is available. Da Vinci XI. In West Bengal, there are only the 2 Da Vinci XI, and when the other hospital has taken at least I think 18 months to complete 100 surgeries, we are already 120 surgeries in 8 months. Proven outcomes according to the global benchmark. We are preparing a paper for that also. Shorter waiting time. So saturation in the metro cities are already there. They are leading to no vacancy and long wait list. Now here, faster scheduling of surgery. In my OPD for cancer, whenever a patient comes, the patient is going to get the biopsy and the scan on the day itself. Within 48 hours, the biopsy report is going to come, and we are taking him or her up for robotic surgery in 48 hours of time. So 2 days OPD to OT time. So thank you. Not all cancers are pink. Not all of us can do great things, but we can do small things with great love. Thank you.
थैंक यू डॉक्टर साहब. बट यहाँ पे जो इसकी कंज्यूमर कास्ट कितनी आएगी इतनी है एक सर्जरी में? कंज्यूमर्स के रोबोट के लिए कुछ होता है?
हाँ सर, कंज्यूमेबल्स होते हैं. ये कंज्यूमेबल्स डिपेंडिंग ऑन, सपोज जैसे सीज़र आप लोगों ने देखा, तो एक सीज़र 10 में यूज़ हो सकते हैं, वो मैंने 10 लोगों में, 10 पेशेंट्स में, तो वो डिवाइड करके हम लोग कर लेते हैं. तो कंज्यूमेबल्स हम लोगों ने जो देखा है कि एक पेशेंट के लिए कंज्यूमेबल्स होता है 3 इंस्ट्रूमेंट के लिए 75,000 तक. दिस सेम थिंग आप कंज्यूमेबल में अगर आप टायर 1 सिटी में जाते हैं, तो जैसे CGHS का रेट है वैसे ही ये बढ़ता है, एंड इट इज़ ऑलमोस्ट 1.5 टाइम्स फॉर कंज्यूमेबल्स. दे आर टेकिंग मोर फॉर रोबोटिक इंफ्रास्ट्रक्चर, एंड दैट इज़ इन 1.15 lakhs जो यहाँ पे मिसिंग है.
Before we open, I have a question too. Yeah. You said presentation to OT is 48 hours. Yeah. So do you not go through a process of tumor board discussion before taking up
yes,
the...
Yes, that actually 24 hours is needed for a biopsy. A typical biopsy report takes 24 hours. If the surgeon and the oncopathologist both are at the same mission to cure the patient, 24 hours के बाद बायोप्सी रिपोर्ट आता है, उसी शाम को हम लोग MDT करते हैं, and the next day the patient is referred either to oncology for chemo या फिर मेरे पास for surgery. So 48 hours is the time OT to DOT to OT time या DOT to chemo time.
So your tumor board typically does not have everyone together discussing a cancer case?
No, the typical persons, first is surgical onc, med onc, rad onc. एक हमारे यहाँ पे रेडियोथेरेपी है नहीं, तो रेड ऑन्क के लिए हम लोग बाहर से बुलाते हैं, एंड रेडियोलॉजिस्ट एंड ऑन्कोपैथोलॉजिस्ट. दिस 5 person has to be there, and if it is gynae case, general gynecologist has to be there.
Any questions from the... I asked that because I think that's the standard of care for any cancer patient.
Every patient. Thank you.
If not, then yeah. Thank you so much.
Thank you so much, sir, for this session. I would request sir to please be on stage. Thank you so much, sir. I would request both the moderators and the chairperson, Dr. Thakur and Dr. Vinita, to please felicitate Dr. Arnav, sir. Please give a huge round of applause. It is my pleasure to introduce to Dr. Ashish Krishna, Consultant General, Laparoscopic, Obesity and GI Surgery, Robotic Surgeon, Mission and Hospital, Durgapur. He stands as a leader in modern GI surgery. Please join me in welcoming Dr. Ashish Krishna, sir. Please give a huge round of applause to Dr. Ashish Krishna, sir.
Anyway, till this opens up, good afternoon, everybody. After the lunch session, we had some wonderful talk from the pediatricians as well as our cancer surgeon, and last but not the least, Dr. Satyajit Bose. Because of him, we are here, and we had a golden opportunity of working on Da Vinci Xi. Though I was introduced to Da Vinci in 2013 in Pune, where I was doing my fellowship with Dr. Shailesh Puntambekar, known oncosurgeon. He is also known for his first uterine transplant in India, as well as first successful transplant, uterine transplant in Asia. So I was very fortunate at that time, but at that time I used to think that whether I will be able to do myself or not, because we used to assist and see, and we used to think it is something for oncosurgeons and it is not for general surgeons. But being a general surgeon, now I can tell you, after operating almost 75 cases here in last 6 to 7 months, that it has totally changed my way of operating in general surgery, my open surgery, my laparoscopic surgery, everything. And why? I will tell you in subsequent slides. So I'll just introduce myself again, that I am Dr. Ashish Krishna. I am working as a senior consultant GI and robotic surgeon in Mission Hospital, Durgapur. So it's almost 10 years now here, and last 8 months we have been provided with this opportunity. We have been trained by Da Vinci, especially we went for the exercises and everything, and it was quite helpful in the long run, because what we were doing is, we used to think as general surgeons, sitting over here will accept that after laparoscopy we can do everything. What's the point of doing robotic surgery? A lot of cost involved and everything. But once you start doing it, then you understand what are the benefits, and when the patient's response you get, you understand that it is just the beginning, and perhaps it is the future. So I think a lot of the slides will be repeated, because we share the same platform. So I'll just sum it up, and then I'll go to the major part. So surgical journey, as we all know, it started with open. So nobody or no instrument can make a bad surgeon a good surgeon. Ultimately, whatever we are doing, whether we are doing laparoscopically, in minimal invasive ward, we are doing robotic, whatever, it is what we have learned, what are the principles which we learned in our open surgery. So we graduated, because what we saw in laparoscopy after doing gallbladders, that laparoscopy totally changed the scenario. In last 30 years, now people demand that we don't want an open surgery, we don't want an open scar. So over a period of time, like I can say in last 10 years, we have seen robotic surgery has taken a little bit of space of laparoscopy. And why is it so? Because as in the previous lecture, Dr. Arnab already mentioned, pain is something which is, historically, it has asked surgeons to be, give small incisions. The surgery should be painless or minimum pain possible. So here it scores the most. So everybody needs a keyhole surgery, there is no doubt. What are the limitations of laparoscopy? Already discussed. Technical difficulty. When I started learning my laparoscopy, I realized it's a difficult thing because because in Calcutta, from National Medical College, my teacher, Dr. Mrityunjay Mukherjee, he used to do excellent open surgery and we used to totally copy him. And we used to think this is the thing, if you do good surgery, you give good results. That is what the patient wants, that is what the surgeon wants. But later on, when I went to Delhi, I realized that now is the era of laparoscopy. The patient comes and asks, sir, whether you can do laparoscopy or not. Then I realized, okay, I have to learn laparoscopy and I have to update myself. Because the patient is also concerned with the scars, with the pain, and they want to continue with their lifestyle as soon as possible. So, as I was talking about the limitations, so one of the most difficult part is the technical difficulty in handling the instruments, because what we were used to was, 3D vision, and we were able to use our wrist properly. But when we are doing laparoscopic surgery, our instruments use to and fro. We can rotate it, but we cannot bend it. So suturing was very difficult. Lot of people are doing laparoscopy, but still they have difficulty in suturing. The reason being, we only have 4 degrees of freedom and long operative times till, I think I have done almost 500 cases of my laparoscopy cholecystectomies. After 500 cases, I managed to, cut down my time from almost 1 hour to 30 minutes. So it takes a very long time. And last but not the least, we are also dependent upon our surgeons, assistants, who are holding the camera and always showing us. So there has to be a compatibility between the assistant as well as the surgeon. So because the assistant is you are totally dependent on them because they are your eyes. So there are other factors, the surgeon factors also. What are the surgeon factors? Like in difficult dissection, if you are not a regular laparoscopic person, then sometimes it becomes in adhesions and some stuff, it becomes really difficult to operate. Surgeon fatigue is something which we don't talk about, but after doing 7 cases a day, shoulders are bound to give way. And obviously surgical expertise, so individual, you must have heard, there are individual laparoscopic surgeons who can do anything. There are people doing Whipples also with laparoscopic surgery. But how much time they are taking, how much they are better, we cannot have a standard of 100 laparoscopic surgeons doing the same type of laparoscopic suturing and giving the same results. So now coming to the robotics. So first and foremost, robotic surgery is not a surgery which is done by the robot. Generally, for a layman or even for people who are not accustomed, they will think the robot will do surgery and it can make no mistakes. So again, I will correct that particular point. Whatever is doing is the surgeon. Our hand movements, they are being replicated through current to the patient's cart, and those instruments are, if we don't do properly, the instruments will also not do properly. What we are gaining from robot, that I will discuss in my subsequent slides. As discussed already, there are 3 components: console, patient side. So we require a very big OT. We require these 3 major portions. All 3 are required for doing the robotic surgery. Console is the place where we sit, and the patient side cart where the patient lies, and the instruments are with the port, they are fixed. So how is robotic surgery different? So already this slide was mentioned earlier. See what we are doing, we are just sitting on a console and we are looking as if we do in open surgery. We are totally immersed in the body. When we look through the 3D system, and it is not a 3D system, there is a 3D system in laparoscopy also. But what is the difference? See, I have worked on 3D laparoscopy also, and what I realized is you have to wear specs. You have to see inside. It can never be the same because the camera is being held by the assistant, whether he might be a doctor or nurse, whatever, there is always some shake associated with your hand. So what happens, there is always a blurring vision which is coming in 3D when you are doing with 3D with other setups. But what is happening here, you are just, as if you are seeing inside the abdomen, you get a real vision. And the magnification is almost 10 times. Sometimes we are able to see the small capillaries as well as the lymphatic system also. Because it is not just that we have to blow up the picture or the pixel size increases. It is also, it has to be very precise. So Da Vinci provides that platform. And also, as in the third part, on the extreme left, we can see it is between the thumb and our index finger. We are playing with these two things. And another we can see, that is the ligature used by robotics. See, ligature we also use in laparoscopy, even in open surgery. But their ligature, it is, until and unless we use it, we cannot understand that. The technology is slightly different. In there, we don't have charring at all. And stickiness is absolutely not there. So we are very confident. We take almost 6 mm, 7 mm blood vessels. We can easily coagulate and we don't even have to clip them. So to robot or not to robot, that is the question for general surgery. And is it better? So is it safe? Definitely it is very safe. Is it easy to learn? See, again, this point, whether it is easy to learn. A lot of people think, again, I have to learn a new technology altogether, and then I am already doing laparoscopy, and why should I go to... See, unless and until we try the new technology, we will not understand what is good in it. And as far as, because I had only seen, I had not operated earlier, when I was trained in my hospital through Da Vinci, what I realized is, because I am almost doing an open surgery with my knowledge of laparoscopy. So, combining open surgery and laparoscopic skills, I am doing better in robotic surgery. So, after 20 cases, what I realized was I am doing those critical cases for which the robot is meant. Can we afford it? See, nowadays, this is a very, this question was asked earlier also with Dr. Arnab. See, I can say that things are changing. There are a lot of people who can buy cars for them. They can also travel in Maruti car, but they will like to prefer a Mercedes. Why? So it is about the comfort. So for our health, one has to pay for it if you want comfort. We can also get the same surgery done open also, but why people shifted to laparoscopy? Because they were getting in comfort, because with 4 holes, after 3 days they can go home, they can start doing their work. Hernias are prevented, lot of infections are prevented. So we are doing it much better through robotics. So even insurance has started giving. From 2022, there is a Supreme Court order that those people who have taken an insurance policy, they cannot be denied of new technology. So a lot of people are getting full reimbursement from insurance companies in our hospital. So whenever we give an option for a patient, what do we think? So whenever we give an option, the first and foremost thing is whether the surgeon is confident or not in doing that particular surgery or not. So if we go to a surgeon and that surgeon is not doing laparoscopy, he will never suggest a patient to go to undergo a laparoscopic surgery. The same applies for the robotic surgery. That robotic platform should be available there. So still in West Bengal, if we consider it by population, I think the population is so much, and still there are only few centers where you will get robotic surgery. And we are very lucky that in Durgapur, we have this facility available. In Calcutta, there are some institutes, those have some older generation Da Vinci. Apollo has taken Da Vinci XI, but on a different module, whatever. But there are very few hospitals. If you go to Delhi, practically every third hospital has a robotic surgery unit now. We always pick up advanced surgery quite late in West Bengal. In Delhi, laparoscopy started a lot early. When I was a PGT in 2005, my teachers were learning laparoscopy. But what we saw is those people who started doing, and see, until unless we start doing, we cannot teach others, our juniors also. So those people who learnt early, they were able to teach their students early. and it will be incorporated early. So if you go to Bangalore, all the major hospitals, they are having robotic surgery done. So why? Because their seniors, they started it early, and the juniors, obviously they learned the tricks, and they are all doing robotic surgery now. So what we have seen is to offer a patient, apart from the scarring, apart from the infection rates, apart from returning to the normal activities or hospitals say, the caliber of the new technology which the surgeon is comfortable, that also matters. Lot of patients used to go for laparoscopic surgery to Chennai, as already mentioned by Dr. Arnab. But still in Chennai, there are very few centers who are doing robotic surgery. So you go to a premier institute in Chennai, still they will not offer you a robotic surgery because they don't have the robot. It is not the fault of the surgeon. There are some excellent surgeons everywhere. So what actually happens in robotics that takes it apart from laparoscopy? See, what is the keyword is the precision and accuracy. We talk a lot about precision and accuracy. What do we mean by precision? We mean the motion scaling. See, whatever we are doing on the console, it is again monitored by the softwares of the Da Vinci system, and our tremors and our scaling is done by that software, and then that current is sent to the, it happens in nanoseconds. So whatever vibrations, whatever tremors, they all are they all fade up, and it is very steady. So when we are going in narrow spaces, this helps a lot. Obviously minimal invasive because it has small ports, size of the ports is small, but small ports, that much doesn't matter. As I already told, the technology is different, that causes less pain. Enhanced visualization, 3D vision, Firefly mode discussed by Dr. Arnab already, which I will tell you how it helps us in even gallbladders. Improved ergonomics. So I will come down to ergonomics. See, if the surgeon is comfortable, you will get the best out of it. Whenever we are doing, any surgeon sitting here will vouch for that, whenever we are doing laparoscopy, suturing on the roof is hell. Gynecologists, because they have to always suture in the, the lower part, it is easy. But suppose in hernias, you have to suture to the roof. Then it comes, and then we realize, however proficiently we do, but there is always some sutures are loose. Sometimes even barbed sutures came to overcome that, but what we have seen, barbed sutures are not the, ultimate solutions, because overall what we have seen is that they are not giving that much good results what we had expected them to. Over a period of 5 years, what we have seen, over a period of time, they do ultimately get loose. So how are we going to be certain about that our suturing is going to be perfect? So otherwise, the better outcome because of pain-free small scars, they do apply for any surgery. So another important thing which is not relevant for him, I will tell you, image inversion. This is a very beautiful thing. This is a little bit of a gimmick that is played by the robotic system. What happens is, when we are suturing on the roof, there is a system in our robotic system that we can change or flip the view downwards. Like if we are operating on the roof, it will look, when we look on the screen, it will look as if we are working down. See, as you can see up, we are suturing backhand, but it is slightly difficult. But when you see that, when your brain is thinking that you are working on the floor, you suture it like as if you are suturing in an open surgery. So this is something that helps in ventral hernias, and I have myself used it. It is one of the best techniques, and I have never seen in any other thing. This is the best thing I found for general surgeons. So ergonomics for surgeon, ergonomics in surgeon benefit, very few people talk about it. I will not, because of time constraint, but when you sit over there and you don't even wear a mask and gloves and you keep operating and you take a break, it helps me, because I have operated almost 17 cases in a day in laparoscopic surgery, and after that 2 days I could not straighten my back. But that is not the case with robotic surgery. Obviously, you can sit, you can walk, you can do whatever you want. You can even go and talk to your assistants also on the bedside, because you are totally free. So this ultimately prolongs the surgeon's career also, because it is helping you in your postures, it is helping you in your, I had a tennis elbow for last 3 months. because every time I suture, it pinches me on my lateral condyle. So anybody who is doing more than 5 or 6 cases per day in laparoscopy will vouch for that. All these things ultimately matters because my health is going to reflect on the patients what work I do. So what are the surgeries that can be done? See, don't think gallbladder is a small surgery. Gallbladder, lot of any gallbladder injury can, most catastrophic injuries in gallbladder are the bile duct injuries, and anybody knows who has faced that even one case can bring you down like anything. I'm talking about mentally. Forget about the professional life and everything. So every case is important. I always say we have to, even for a coli, we have to, even a single injury should be prevented. And our robotic system helps in that. Hernia surgery, as I told you, suturing is very good. Optics are very good, so we are able to handle big hernias, big scrotal hernias in that. Bariatric surgeries and pelvic surgery. Pelvic surgery, I will just mention one thing, because it is a very narrow place, specifically in males. Males, the pelvis is small. When we are doing rectal surgeries, when we are doing rectopexies, it is very difficult in open surgery because you cannot reach there. It is very difficult in laparoscopic surgery because it is very difficult to move your 360 degree to 180 degree your instruments over there. And I have faced myself, one of my sutures, I could not take it properly and there was a recurrence. So I don't shy with that because that is the problem with the laparoscopic surgery. Even in open surgery, it has been seen that when you go very far, the vision gets compromised.
Time over, please.
Yeah, I'll just take 2 minutes, sir. So, inguinal hernia, as you talked about, as you can see, with just instruments, these instruments can rotate wherever I feel like. I'm doing the same laparoscopic principles, same open principles, but my precision is very good. I can see those layers which I used to be taught in my anatomy books. The transversalis fascia has 2 layers, which I could see only in robotic surgery properly. I used to do a lot of laparoscopic hernias, but I became confident and I was so sure when I was operating near my femoral canal that I can see all the veins and I can see them in, so that I cannot even, just injure even a small capillary also over there. So you can see my gauge piece is there and it is not even stained. It was deliberately kept to show it is not an edited video. It is just fast forwarded so that I can save time. Another important thing is that whenever we are placing meshes, we are doing just suturing. We are not placing any tacks. Lot of people are complaining of tacks, neuromas. Neuromas cannot be treated unless you do neurectomy. Neurectomy is again a painful procedure. So it's very easy. You are saving cost from, those very costly meshes. Also, you are saving on tackers. And suturing is really easy. After 2 cases, you will think even you can suture on a robot. So ventral repair, again, I'll just show you. This is, I am taking on the peritoneum. I am not placing a dual mesh inside. Dual mesh is one of the worst possible procedure that can take place because you are placing a foreign body inside. So it has always, so as you know, what we operated 20 years back, now we are realizing those people are presenting with adhesions, those females are coming with, lot of problems with adhesions and even intestinal obstructions. Day before yesterday, I operated a patient of intestinal obstruction in which a dual mesh was used. So with robotic surgery, what we can do is we can just peel this is TAPP I'm doing for an umbilical hernia. Just 1 layer cell thick, I am pulling the peritoneum down and then I will be able to put a simple mesh, Proline mesh, 4,000 rupees mesh. So this is rectopexy I did around 10 days back. Again, this was a male patient and it was actually the patient came from Calcutta because he was everywhere told either you go for open or you go for laparoscopic because some people, they were not trained in it. So I agree to that. But this patient was discharged the next day. Can you believe that? Because all my open patients I do rectopexy.
Doctor साहब session बहुत late हो रहा है ना, please.
ठीक है sir, thank you.
है ना? Sir, any contraindication of robotic surgery इतने फायदे के बाद?
Yeah, definitely. Contradiction is first and foremost is anything in which general anesthesia cannot be given, robotic surgery cannot be done. Even laparoscopy cannot be done. You have to do open surgery in that.
Just one more question. From gynecologist point of view, I understand that, if it's a simple like ovarian cystectomy and can be done laparoscopically, then robotics should not be your first choice. Similarly, if it's a simple lap chole and you said you can do it in 30 minutes, then those patients should be done by laparoscopic. So not all patients.
Ma'am, I will totally agree. First of all, robotic surgery is not meant for simple cases. It is meant for complex surgeries. But as a teacher, as a surgeon yourself, what you will understand is how do we ultimately reach to a point that we are doing endometriosis robotically, or because we started it in an open way and we started doing easy cases first, and then we went and started doing it is the same with any surgery. You have to start with the easy cases. When you are accustomed with the system, however easy it is, even in open, when we were taught in our college, we were told कि जो सबसे पतला बच्चा हो या सबसे जो है अच्छा जिसको ज़्यादा एडिशंस ना हो उसका अपेंडिक्स पहले करना है, then only you will learn the anatomy and how to handle the tissue. First you should learn how to handle the tissue. So anything which is simple, like as you said gallbladder, I will say when we are doing it robotically, we are doing ICG, we are giving ICG. The whole roadmap is there with us. We know where is the duct, nothing is by chance. I just operated, in fact, one of the patients, a relative of Dr. Bose. In fact, I did robotic cholecystectomy because he was advised robotic cholecystectomy in Apollo, and he came over here and I operated. And you will not believe, out of my 30 cases, that was the first case in which I got an aberrant duct. And that was because of the excellent vision of it. And I tied it because I knew when I will be when I'm taking the gallbladder, I was not sure because there was some, we get the greenish discoloration. So I could suture on the liver itself.
So we'll end the session and some questions can be taken offline. Thank you.
Okay, thank you.
Thank you so much, sir, for this session. I would request the moderators to please felicitate Dr. Ashish Krishna, sir. I would like to inform that high tea session is going outside in the lawn, outside this hall too. I would just request everyone, we are running out of time, so everyone could join the high tea session, but we will continue the session here because we are really late with our sessions. Thank you so much. I would like to invite Dr. Vinita Dwivedi to please felicitate our moderators, Dr. Vinita and Dr. Thakur. Dr. Vinita. We would begin with our next session, that is Symposium. And for Symposium, the topic would be platelet-rich plasma therapy. For this, the moderators will be Dr. B.B. Karunamay and Dr. Jayant Kumar Acharya. I would like to please call these moderators on the stage. Now I would welcome our esteemed speakers for Symposium. Our first speaker will be Dr. Jayant Kumar, presently working as consultant and unit head orthopedics, Tata Main Hospital, Jamshedpur. Our second speaker for Symposium will be Dr. Abhinita Das, consultant, Department of Dermatology at Main DSP Hospital, Durgapur. Please welcome our third speaker, Dr. Deepak Kumar Dashmo Mahapatra, Consultant Department of Surgery at Bhilai Steel Plant. I would request to start the session. Thank you. Now I would like to call our first speaker.
Yeah, thank you, Anshika. You have been doing a great job right from the morning. Need some appreciation for that. And congratulations to the organizers of the Aismoc for doing a fabulous job. First day has been quite exciting. So till they prepare my slides. So compared to the last session, this is something easier, I would say. Anybody can do. Jayant Kumar. this topic is quite, I would say, a hot topic and a relevant one, and a nice selection of this topic. And yeah. So platelet-rich plasma, I would be talking about this therapy in orthopedics. Now, in orthopedics, there's seen a quite surge in the recent decade, and if you just do a Google search, over 300 peer-reviewed documents you would find on PRP in orthopedics use. And what's most exciting is that more than 50% of this literature is what is level 1 and level 2 evidence, so that you can directly rely on it and start implementing it in your practice. The reasons why so much of interest has been shown in PRP as the leading and most researched orthobiological agent is that it's the least controversial, being autogenous in nature, blood being taken from your own body, and the ease of application, and that's very economical also, and yet it is giving very good results. Now, if we look at the mechanism of the platelet-rich plasma, it's not as simple. It looks like the whole work is being done by the platelets, but it's a complex dynamic biological system where it's the platelets along with the other cellular elements, the leukocytes, the fibrin, and sometimes a detrimental effect of the erythrocytes that may act as a contaminant in your platelet-rich plasma. So it's an interplay, it's a buffer system of all these things which actually play the mechanism. But yes, the platelet is right in the core of this mixture, and within 10 minutes of its injection into the body, when it coagulates, it releases the alpha granules which have a lot of growth factors in them. The most important being the platelet-derived growth factor, the transforming growth factor beta, the vascular endothelial growth factor, and the epidermal growth factor, and there are many others also. But what they actually do is they modulate the inflammatory process inside the tissue space where you have injected it, stimulates angiogenesis, and then thus they stimulate in formation of new tissue and healing of the tissue. But to do all these things, what is important is that the concentration of platelets that I have written below is the working platelet-rich plasma formula, is that it should be at least 5 times the concentration in the normal plasma. So it should be around, somewhere around 1 million platelets per microliter, and then only these functions happen. So in order to get these functions happening for orthopedic surgery, now what's most important is the processing of the sample to get that correct platelet-rich plasma available to the patient. Now in Tata Main Hospital, we already are doing this platelet-rich plasma therapy for our patients. So what we follow is actually what has been recommended for orthopedics as per the studies done by PGI, which is PGI Chandigarh, which is one of the pioneer in this technology in India at least. So we harvest around 60 cc's of atraumatically, it's very important to atraumatically harvest the 60 cc of blood. The volume is very important. With an anticoagulant, we use the CPDA. Then we do a double spin centrifugation. Now this is very important for orthopedics, because what the double spin does, as you can see in the figures below, it gives us a more purer form of the platelet-rich plasma with less of leukocytes compared to a single spin. Still, it is a leukocyte rich because we are not using a filter to remove the leukocytes from this plasma. And once we have this solution, we generally inject all our patients in the theater. So it's a sterile ultrasound guided injection. And most importantly, you can see the cost there at TMHs comes to around 35-50 per patient. So now if you look at the evidence where it has been used in orthopedics, so as I said, there are so many articles, and the last decade has seen a sudden surge of articles and very high level studies. Level 1 studies we can directly start implementing in your practice is for knee osteoarthritis, elbow tendinopathies like the tennis elbow and the golfer's elbows, gluteal tendinopathies, and plantar fasciitis. These are the 4 conditions which have shown the best results on longer follow-ups and can be started using right away. Certain other conditions very common to orthopedics like the cuff, rotator cuff pathology, the frozen shoulder or adhesive capsulitis, the decurving stenosynovitis of the thumb, the carpal tunnel syndrome at the wrist, they also have shown moderate to good evidence when you use PRP. But there are certain conditions like the Achilles tendinopathy and the patellar tendinopathy where even though it has been used, it has not been showing consistent results, and the evidence is conflicting. Hence, they may not be recommended for the daily use as of now. Now the most researched one is the orthopedics, as you can see, in orthopedics is the osteoarthritis. As you can see, there are a number of articles and most of them are meta-analysis of the randomized controlled trials which are level 1 evidence, and then what they are showing is that this platelet-rich plasma has been found to be most effective for the knee osteoarthritis, followed by ankle and then by hip. What they have shown is that they not only reduce the pain of the patients, but they also improve their functional outcomes in terms of the WOMAC score and the pain as measured by the VAS scale. And the patients that you should target for this therapy are the osteoarthritis grades 1 to 3. And the effects have been seen to last for at least 12 months, which is quite a big time period. And what is important is that you use a platelet processing mechanism that gives you a high platelet content of the PRP, which is only possible if you harvest atraumatically high volume of blood, at least 50 to 60 cc, to get this processing done. PRP has been shown to be better than the hyaluronic acid or corticosteroid or saline injections given alone in the knee osteoarthritis, and younger patients have been shown to do better than the elder ones. If you make a cocktail of PRP with a hyaluronic acid, that also has been shown to be safer and a better option for in terms of outcome, in terms of pain relief and functional improvement. So next is the elbow tendinopathies. They also have been shown to have the same good results, with the results lasting up till 12 months. But what must be understood that PRP in itself does not generate new tissues. So for conditions like bone fusion, AVN and cartilage regeneration, it should not be used. The future holds where we have started using the scaffolds of the collagen and adding peptides with PRP and mesenchymal stem cells with PRP, and that is the future where we can also regrow tissue with PRP. So just for final practical points, my last slide is, we should not be taking NSAIDs with the PRP, because PRP does produce some pain for a week or so after the injection. Avoid that because it's an antiplatelet drug. Similarly, those on antiplatelet drugs like clopidogrel and aspirin should also avoid using PRP injections. Dosage is critical, as I said, 60 cc blood should be withdrawn, and good glycemic control, lipid control patients have been shown to have good results. Thank you.
Next one. Yeah.
Good afternoon, everyone. Today I am acquainted with what is PRP, how do we process it, and the mechanism of action. So I will briefly touch upon the basics. PRP is an autologous, minimally invasive regenerative medicine procedure using patients' own concentrated platelets to stimulate healing and tissue regeneration. Its primary use in dermatology is in wound healing, hair restoration, skin rejuvenation, and it is also found to be beneficial in scars, striae, and certain inflammatory dermatosis. In dermatology, we use often in combination with microneedling and fractional lasers for synergistic results. Thus, PRP is one of the simplest, least invasive, relatively safe, and highly effective procedure that boosts tissue healing and remodeling. We have seen that it is the most natural injectable, that it is autologous, coming from the patient's own body. Here we see a test tube with centrifuged blood, where the blood components have been separated. The middle white thin layer is the buffy coat layer, which is the concentrated WBCs and platelets. This is the part that is extracted and used for PRP therapy. As we know that the main function of platelets is blood coagulation. Apart from that, it has a host of other functions, like in immunity and inflammation regulation. This contributes to the effects of PRP therapy. Platelets play an important role in all of the 4 stages of tissue healing, starting from the blood clotting, that is the hemostasis phase, and following this, platelets release a host of growth factors which aid in the next few phases, that is the inflammatory phase, proliferation phase, and maturation phase. The predominant growth factors, we have already gone through them. There are 7 major ones, PDGF, VEGF, TGF-beta, EGF, CTGF, insulin-like growth factor 1 and 2. The action of most of these growth factors is mainly new blood vessel formation, tissue regeneration, that is by cell proliferation of the stem cells and epithelialization, extracellular matrix formation, collagen synthesis, and regulation of inflammatory process. There are certain newly reported and less known effects of PRP. These are anti-apoptotic effects, immunological suppression, decrease in melanin synthesis, antimicrobial effects, and antioxidant effects. These effects too help in certain indications of PRP. I am not going into details of the procedure as it is the same that we have seen in orthopedics that is being done. Here we see a centrifuge machine. Inside the chamber, the test tubes filled with whole blood is placed in diametrically opposite ends and the lid is closed. Parameters, that is the speed and the duration of time, is selected. The speed is denoted in revolutions per minute or RPM. Coming to its applications in dermatology, we have seen that PRP has a wide range of applications. Wound healing is a common application. Beneficial results have been seen in pressure ulcer, venous leg ulcer, diabetic foot ulcers, and a few cases of pyoderma gangrenosum, which is an inflammatory condition. The major pathways involved are revascularization, regeneration, and replacement of damaged tissues. Antimicrobial effect gives additional advantage. Hair restoration in androgenic alopecia and female pattern hair loss is one of the most popular uses of PRP in dermatology. Its action is through angiogenesis, hair follicle proliferation, and the lengthening of the anagen phase. PRP has also been found to be beneficial in alopecia areata, which is an autoimmune condition. Its benefit is possibly by down-regulation of apoptosis, and it is also beneficial in scarring alopecia, possibly through immunological suppression. Here in this image, we see the effects of 6 months of monthly sessions of PRP in both male pattern and female pattern baldness. In this image, we see PRP being used for facial rejuvenation. On the upper image, we see PRP being used as a temporary filler for the nasolabial folds. In the lower left corner, we see the effect of PRP in acne scars. In scars, we often use it along with in combination with subcision and microneedling. In the lower right hand side, we see PRP being used for melasma, which is a pigmentary condition. It is interesting to note that in comparison to the other modalities of treatment which we use for rejuvenation, PRP acts on all the 3 levels of the skin, that is the epidermis, dermis, and the subcutaneous tissue. Here we see how we inject PRP for facial rejuvenation. It is injected in very small doses at multiple spots, and the layer of injection is in the dermis and subcutaneous tissue. The method is called the linear injection or mesotherapy technique. Coming to the advantages of PRP, we have already seen that this is a minimally invasive procedure. It has a very favorable risk-benefit ratio since it is autologous. There is no risk of rejection reaction or bloodborne infections. It is highly convenient and cost-effective. Side effects are minimal. Some edema and bruising may occur. We need to keep in mind certain potential complications of embolus or thrombus formation in case of intravascular injection or nerve trauma at the site of injection. The absolute contraindications are critical thrombocytopenia, platelet dysfunction, hemodynamic instability, sepsis, and local infection at the site of PRP administration. There are certain relative contraindications such as medication use, such as NSAID use, glucocorticoids, and anticoagulation therapy, any recent illness or fever, malignancies, anemia, mild thrombocytopenia, or tobacco use. Thus, exploring further additional and emerging applications of
Madam, time
PRP
is over.
in dermatology is, just a few seconds, burn and radiation-induced dermatitis. It is useful in vitiligo and melasma, in striae distensae, periorbital hyperpigmentation, and in vulvar lichen sclerosis. Overall, PRP is valued for its favorable safety profile, minimal downtime, and autologous nature. Thank you.
Namaskar, all respected head of medical institution, my senior, my delegates and my colleagues. Actually, I am not a surgeon, but I am fortunate to speak on this. I have quite a few experience on PRP therapy. Actually, as I quote in the first slide, you can see natural forces within us are the true healers of the disease, long back told by Hippocrates. Consequently, these are the cytokines and PGF factors which secretes from various sources. Platelet count, higher the number of count, better the result, as I told. Few authors suggested that dose response curve mostly depends on the growth factor. Few authors suggested, but sometimes higher concentration when the cell surface receptor is blocked, you increase the dose, the effect won't be there. Also keep it in mind. And already I have told that the leukocyte count should be less, and AABB also recommend this. It should be less than 5 into 10 to the power 6. Dose response depends on, as I told, initial volume of whole blood taken, that is the platelet count present in that whole blood. We calculated the circulating PRP have a lifespan of 7 days. Usually, few surgeons prefer directly injecting the PRP, few prefer activating through the use of thrombin. Autologous PRP, as I told, PRP is mostly autologous only. And tendon, and it is used in tendon and ligament repair. PRP injected into damaged tendon and ligament, promoting regeneration and decreasing pain associated with injuries. Joint surgeries utilize platelet-rich plasma to enhance healing in joint tissue, reducing recovery time and improving outcomes. In scar treatment and wound healing, enhances the healing process of scars by increasing the blood supply and cell turnover. Facial rejuvenation. Dentistry also, PRP therapy promotes fast and effective healing of hard and soft tissue in the mouth. PRP has effect in analgesic also. Activated platelet release many pro and anti-inflammatory mediators that are proficient in reducing inflammation and pain. These are supporting articles. Yes, I want to highlight the regulatory issues. Currently, India has no regulations over this. And in conclusion, PRP preparation is extensively used in wound healing and tissue repair. Blinded multicentric with large sample size is required to establish their therapeutic efficacy. Threshold dose required for therapeutic benefit is not defined for different clinical indication. Guideline is needed by regulatory authorities like CDSCO to ensure its rational use. No adverse event has been reported till date, but patient safety still remain a major concern. All this emphasizes the role of transfusion medicine specialist in the assuring quality, consistency and safety of the product. Thank you. These are my references.
Thank you, Deepak. This is a very warning topic, this PR.
I'll just, before they put their questions, just only two things I like to know. Is there any controversy regarding the leukocyte-rich PRP versus high leukocyte-rich PRP or low leukocyte? That is number one. And second is how long is the sustainability of the advantage of PRP, especially in dermatology?
Sir, as per my experience, leukocyte depleted products are better, sir. I use actually PRP Remi Ultra. One machine is there. It's actually maintains the temperature and also take care of that leukocyte depletion part. Because when we are using leukocyte rich products, sometimes inflammation will be there. See, there is controversy also. But my personal experience, leukocyte depleted product is far better. It's my personal experience, sir.
So in orthopedics, we have two indications basically. One is where we want to, actually repair the tissue, like in tendinopathies. So there we need induced inflammation to happen there. So those areas we use a leukocyte-rich PRP because of the white blood cells inducing some local inflammation there. The other condition is when, like the degenerative conditions like the osteoarthritis, where we are more concerned on pain relief and that leading to a functional outcome, better outcome. There we prefer what sir is saying, leukocyte poor. But again, having said that, the meta-analysis do not show that it's actually in the long term making any difference in the results.
Thank you so much for this amazing symposium. I would like to call upon our Dr. R.R. Kumar sir for felicitation for the moderators and the speakers.
1 year. 1 year generally, the level 1 studies in osteoarthritis at least, tendinopathies 1 year.
We would begin the felicitation with the speakers. Our first speaker would be Dr. Jayant Kumar. Second speaker would be Dr. Nabanita Das ma'am. Third speaker would be Dr. Deepak Kumar. Coming on our moderators, that are Dr. B.B. Karunamay. Second moderator would be Dr. Jayant Kumar sir. I would begin with the last session, that is short PG paper, and the first speaker would be Dr. B.B. Kanda Singh, Rourkela Steel Plant. Our topic would be a prospective observational study on incidence of self-medication in children in outpatient department in a tertiary care center. Before the speaker coming, I would like to invite the chairpersons for this short PG paper, that are Dr. Vinita Singh, GMMS, Tata Steel Limited, and Dr. K.S. Sujit Kumar, Additional CMO IC, VISL, Bhadravati. Please welcome our chairpersons. I would again like to call Dr. Vinita Singh. Is she there in hall 2? Yeah. Please welcome with a huge round of applause. I know everyone is tired, but this is the last session. Please cooperate, everyone. The second chairperson would be Dr. K.S. Sujit Kumar, Additional CMO IC. Is he present in the hall? Second chairperson. I would like to call Dr. B.B. Karunamaya sir to be the second chairperson for us for this short PG paper presentation. The first speaker would be Dr. Singh from Rourkela Steel Plant. The speaker is here. I hand over the mic to you, sir.
Good afternoon, Chairperson, esteemed judges, and my dear colleagues. Today, myself presenting a case on self-medication practices and pediatric outpatients. Self-medication. According to WHO, the selection and use of medicines by individuals, it also using over-the-counter medicines, reusing previously prescribed medicines for similar symptoms, and taking medicines based on from non-medical sources. What are the significant risks associated with self-medication? Incorrect dosing, adverse drug reactions, antimicrobial resistance, and treatment failure. The factors that lead to self-medication, e.g. over-the-counter drug availability, financial constraints, lack of access of medical services, previous prescriptions, and misinformations. So where is the gap in the knowledge? Most of previous studies describe prevalence, reasons for self-medication, and few have quantified outcomes such as inadequate dose, treatment failure, hospitalization. True clinical impact remains under documented always. So despite magnitude of this issue, there is a notable gap. So our study helps to fill this gap by analyzing the outcome data. With the aim of the study to study the incidence of prior self-medication attending pediatric to assess misuse of antibiotics. Evidence sampling, children aged from 1 to used here is self-prepared questionnaire and data analysis through a chi-square where P less than 0.05 is significant. After sample size was children attending to OPD, their screen for self-medication history, then consent was taken and final sample included 626 children. Most common age group 1 fever is the most common symptom reported in then by statistically insignificant. And the various concerns for self-medication, parental anxiety is the most common cause for self-medication. And this was outcome in with past studies. So coming to discussion, majority of children aged from 1 to 5 years with a mean age group of 5.9 plus minus 3.3 years. Similar to Gohar study, male predominance in self-medication. Mothers were the primary caregivers. Most parents aged mostly 31 to 40 years. Fever was the most common indication for self-medication. Paracetamol most commonly used drug. Azithromycin most commonly used antibiotic, similar to Indian studies. And in Western studies where penicillins are predominantly most commonly used. Main source of medication, parental anxiety, dissimilar to Narayan study where reported prior drug efficacy as the main reason. Most common large sample size, improving statistical reliability, conducted in a tertiary care hospital, ensuring diverse patient representation, detailed assessment of demographics, socioeconomic, clinical, and drug use factors are assessed, identification of regions, sources, and outcomes of self-medicine in children was also done. What are the recommendations? Parental education on current dosing and drug risk to be promote consulting a clinician before medication, restrict over-the-counter availability of antibiotics, encourage pharmacists reinforcement on correct dosing, and public awareness on dangers of self-medication. The take-home message, self-medication in children is a major public health concern. Paracetamol and azithromycin are most commonly used misused drugs. Outcomes analysis reveal high rates of inadequate dosing leading to treatment failures. Strengthening parental counseling and stricter regulation of over-the-counter drugs is essential. Self-medication reflects issues in pediatric drug access and practices, which are studied documents at the community level. These are the references. Thank you.
Thank you, Vivekanand. Now, any queries? Self-medication in children.
Step. How are you going to train people? How are you going to make them kind of take it forward? This we have got it, we knew it, now you have actually got it through a paper or a study that this is the problem. Okay. But what is the next step that's more important?
Sir, nextly we are, now it is in OPD basis case, sir. OPD basis, not to...
Yeah, you answered it. So okay. Actually you should have strengthened the health of everyone, all those 626 numbers.
Sure, sir.
In general, the awareness issue. The first thing is when you have found out that they're in pediatric children, so there should be some knowledge given to those patients that why it should not be done. That is very important.
Sir, that awareness with some strict drug regulation is also there, madam. Recently the incident that happened in Madhya Pradesh, the over-the-counter drug availability is very easy in our community population level. So it should be strict regulation also there. The Drug Cosmetic Act should be strict also. Yeah.
That is what is the action plan. That we have to take that.
Okay. Thank you.
Okay, thank you, Dr. Vivekanand. So we can move to the next topic.
Now moving on with our second speaker is Dr. K. Jhansi. Assessment of patients on monoclonal antibodies, a retrospective study. I would like to hand over the mic to Dr. K. Jhansi.
Good evening, all of you. Dignitaries on the dais, off the dais. And my dear delegates, okay. I'm going to present on assessment of patients on monoclonal antibodies. A retrospective study done at Vishaka Steel General Hospital. Monoclonal antibodies, the major class of biologics or recombinant therapeutic proteins that mimic the immune system to fight with harmful pathogens. Whereas in autoimmune diseases, they suppress the overactive immune responses. The monoclonal antibodies, also known as MAB, and they are made by cloning a unique white blood cell. These are the highly specific monoclonal antibodies get attached to the epitopes. This is a mechanism. And when so many therapeutic applications of monoclonal antibodies are there, our study is on autoimmune diseases and inflammatory diseases. Our aim is to evaluate the therapeutic impact of monoclonal antibodies on patients of our hospital by assessing disease etiology, treatment duration, prognosis, and treatment outcome. The main objective is to explore the differences by focusing on our aim. These are the materials and methods. And inclusion criteria. Patients with autoimmune and inflammatory diseases, patients treated with specific monoclonal antibodies, biomarkers, patients with paid data, that is pre and post evaluation was done, and treatment starting date and ending date, and prognosis outcome is improved. They are categorized as improved, stable, and worsened. Improved patients showed disease improvement, stabilized, and the biomarkers were reduced. Whereas in stable patients, the biomarker levels have come down, but side effects were still persisting. In worsened cases, the biomarker levels either reduced or increased after treatment, indicating relapse, and the patient showed side effects and sometimes adverse reactions. These are the exclusion criteria. Study details. Out of 1250 patients records, we have studied 890 patients who were treated with specific monoclonal antibodies during June 2022 to June 2025 for a period of 5 years at location. Clinical data and drugs analyzed were all these: adalimumab, infliximab, denosumab, rituximab, and secukinumab. These were chosen for my study based on their frequent usage within the hospital's therapeutic protocol and their relevance in treating chronic inflammatory and autoimmune diseases. This is the disease etiology based diagnosis, and disease indicators are C-reactive proteins, erythrocytic sedimentation rate, tumor necrosis factor alpha, low density lipoproteins, and glycosylated hemoglobin. These are the objective indicators for disease activity. We have, and grouping was done, and when coming to the results, this is the number of patients versus prognosis outcome. Here 60% of patients showed improved prognosis and 34 patients showed stable prognosis. whereas 6% have showed worsened, primarily occurred due to irregular treatment, complete relapse, or progression of the disease. Here the number of patients on specific monoclonal antibodies. This pie diagram shows rituximab is highly treated with 44.1%. This is drugs prescribed for average treatment duration. Here we can see it's almost 74 to 87 weeks of treatment duration. Average biomarker reduction after therapy. Here we can see this tumor necrosis factor alpha showing 50% of reduction and followed by C-reactive proteins. This column shows highest percentage reduction. This gives the information that the MABs are targeted at disease etiology. This is a percentage reduction in specific biomarker levels. Pre-treatment and post-treatment are analyzed and percentage reduction in their biomarker levels. This is a percentage reduction in specific biomarker levels in like column form. Here we can see influx is 30.1%, whereas followed by retux is 29%. This is a drug safety. Here we can see secukinumab shows almost 36%, whereas rituximab shows 27% of safety profile. With this we can say secukinumab showed higher frequencies of side effects. Gender-wise, this bar diagram shows male patients responded very well. And coming to the discussion, here we can see target sites, patient on MABs, monoclonal antibodies, average treatment duration and side effects, and percentage reduction of biomarker levels. This study also shows influx in terms of biomarker level reduction by 30.1%. The result of this study aligns with the global clinical studies that inflixi is highly potent, whereas rituxi, while slightly behind inflixi in terms of 29% lowest frequency side effects. It was also highly prescribed drug in VSDH as it is a broad choice of a drug as per FDA guidelines. Coming to the conclusion, majority of patients demonstrated improvement or stable disease activity. Longer duration of therapy, more than 84 weeks, was associated with better prognosis. Biomarker levels showed consistent reduction post-therapy. Monoclonal antibodies were effective and safe when monitored carefully. Study supports personalized biologic therapy protocols. Take-home message, consistency and persistence leads to better therapeutic success. These are my references, and thank you.
Thank you, madam, for presenting such a large series of 80-90 cases within 5 years. So a vast experience of the varied etiology. So we can have 2 questions from the audience in this vast series of monoclonal antibody use.
Dr. Jansi, this is Dr. Asif. Very nice. I think 5 years is a very long time, as Dr. Karunama has said.
Yes.
It's a long series. So what we saw was that your study was done during the COVID period.
Yes,
Yeah, and
almost.
COVID period we had used tocilizumab, isilizumab to a great extent. So what was the reason for not including that MAB in your study? Because that was used for almost 1.5 years, if you have to say, from June 2020, your paper started, and then it carried on to 2021. So I think that should have also been taken. Since you're talking about MABs, that was something which was very much in use, and we could have got to know what was the result there.
So what was that MABs you said, sir? Inflixi?
No, tocilizumab, that's what we used for all the cytokine storm. That was indicated for all treatment of severe patients of COVID.
But in our hospital, according to the FDA guidelines, we have used rituximab, sir.
No. That's
Not
fine.
for- not for-
This was this particular drug because this was in use. In
Yes.
fact, 2 years during a study period, this drug was in use.
Yes, sir.
So maybe that could have also given us some insight because it's a large series, 5 years.
Yes.
So that
But-
could have added on to our knowledge.
But we have studied only those 5 drugs which were prescribed at our hospital. For only those 5 only, sir. This was not as you said.
Okay, thank you. Thank you all. We can go for the next topic.
Thank you, Dr. Jhansi. Let's move to the third speaker, that is comparison on nebulized dexmedetomidine and nebulized magnesium sulfate for attenuation of hemodynamic response to laryngoscopy and tracheal intubation. For this, the speaker would be Dr. Lelesh Chandra from Bhilai Steel Plant. Please put your hands together for this speaker.
Good evening, honorable judges, respected chairperson, respected seniors and dear colleagues. I am Dr. Nilesh Chandra from Department of Anesthesia, JLNH RCH, Bhilai. My topic for short paper presentation is comparison of nebulized dexmedetomidine and nebulized magnesium sulfate in attenuation of hemodynamic response to laryngoscopy and endotracheal intubation. Friends, in earlier days of modern anesthesia, laryngoscopy and intubation were thought to be harmless procedures done while the patient was apparently asleep. However, in 1971, Price Roberts et al. In their study showed that laryngoscopy triggers a stress response which causes a surge of catecholamines into the circulation. This manifests as tachycardia, hypertension and sometimes arrhythmias. Even though the patient appears unconscious, this stress response can be can cause huge and potential catastrophic complications in the vulnerable patients. The key lesson is endotracheal laryngoscopy and endotracheal intubation is not just about controlling or securing the airway, but controlling this stress response too. While various agents have been used to blunt this stress response, our study focuses on 2 potent agents which were given via nebulization. The aim of our study was to compare the efficacy of nebulized dexmedetomidine and nebulized magnesium sulfate in the attenuation of hemodynamic response to laryngoscopy and tracheal intubation. The primary objective of our study was to assess the changes in hemodynamic parameters such as systolic blood pressure, diastolic blood pressure, mean arterial pressure, heart rate in between the 2 groups during laryngoscopy and intubation. The secondary objective was to compare any incidence of adverse events between the 2 groups such as hypertension, bradycardia or respiratory depression. The study area was the Department of Anesthesia, JLNH Hospital. The study population was patients who underwent elective surgeries under general anesthesia. It was a prospective, randomized, double-blinded comparative study which was done from January 2024 to September 2024. Inclusion criteria were patients undergoing elective surgery under general anesthesia aged 18 to 60 years with ASA physical status 1 and 2 weighing 50 to 80 kg with modified Malampatti airway grade 1 and 2, patients with history of arrhythmias or uncontrolled hypertension, history of cardiac respiratory diseases, history of alcohol intake, pregnant patients, patients in whom intubation time was more than 30 seconds or patient in whom baseline heart rate was less than 55 per minute or greater than 90 per minute were excluded from the study. On calculation, sample size came to be 39 for each group. However, we recruited 90 patients and randomized them into 2 groups of 45 each, Group A and Group B. Group A patients were nebulized with dexmedetomidine at the dose of 1 microgram per kg and Group B patients were nebulized with magnesium sulfate at a dose of 40 mg per kg. Pre-anesthetic checkup was thoroughly done and only eligible and willing patients were selected. Upon arrival in the pre-operative room, the baseline vitals of the patients were noted. They were nebulized with the study drug. During and after nebulization, vitals were also noted. This was followed by induction of anesthesia and endotracheal intubation. Vitals were recorded at intubation and at 1, 2, 3, 4, 5, 7 and 10 minutes post intubation. Cases were done according to the protocol. Statistical analysis was performed using SPSS software 20.0. Now coming to observation and results. we can clearly see that both groups were comparable in their demographic profile. In both groups, all the hemodynamic parameters remained successfully below the baseline during and after intubation. However, when we looked at time points of T1, T2 and T3 minutes and compared the systolic blood pressure, we clearly see that systolic blood pressure was significantly lower in dexmed group as compared to magnesium sulfate group. Similar was the result for diastolic blood pressure and mean arterial pressure. For the heart rate also, at the time points of T1, T2 and T3 minutes, the heart rate was significantly lower for the dexmed group. In summary, all hemodynamic parameters were comparable. However, dexmedetomidine group showed significantly lower systolic, diastolic, mean arterial pressure and heart rate at 1, 2, 3 time minutes post intubation compared to magnesium sulfate. No adverse effects were noted. Our study showed that dexmedetomidine was superior to magnesium sulfate in attenuating pressure response, which was supported by earlier studies such as Bora et al., Zafar et al. And Mishra et al. Other studies such as Grover et al. Showed that both dexmedetomidine and magnesium sulfate were comparable in attenuating this hemodynamic stress response. But our study adds granularity to this finding. Our study marks the critical time period of 1 to 3 minutes post intubation, where the dexmedetomidine was able to provide tighter control of hemodynamic parameters. Additionally, our data suggests that nebulized route may favor the lipophilic dexmedetomidine for rapid mucosal absorption over the magnesium, providing for the superiority of dexmedetomidine over magnesium in attenuating the stress response. In conclusion, while both drugs successfully control body stress response, nebulized dexmedetomidine had significantly greater impact in suppressing the sympathetic nervous system compared to magnesium sulfate. Thank you. I'm ready for questions.
Thank you. Any questions from audience?
Okay, myself Dr. Manoranjan.
Yes, sir.
How you measure that blood pressure?
Sir, blood pressure during anesthesia is upon automatic cycling monitoring via the anesthesia machine only. It has the monitor which...
Non-invasive. Non-invasive, NIVP.
Non-invasive, NIVP, sir.
So it takes around 30 seconds to measure the NIVP, and you observed 1, 2, 3 minutes.
No, you can set the time minutes to lower intervals also.
No, it takes 30 seconds around to measure that BP.
Automation mein you can set the time minutes. Actually, while doing in a general anesthesia procedure, while we were noting the vitals, you can set the time limit to lower intervals also. So the finding can be set at 1 minute only. The 1 minute intervals can be done.
Okay. You have IV line in this patient. So both the drugs can be given in IV route.
Yes, sir.
So what prompted you to give in?
Sir, that was our motive. Thanks for asking this question. Actually, the respiratory mucosa provided for the larger surface area, and the nebulized route was effective as proved by earlier studies such as Grover et al. And Mishra et al. Secondarily, when we gave the drugs via nebulization, it acted on the peripheral receptors present at nerve endings present at the mucosa of the respiratory part, where we were needed to insert the tube and the laryngoscope. Third, because the respiratory mucosa was involved, the peak of the drugs were slow to rise, avoiding any adverse side effects such as sedation or respiratory depression. Okay. That's why nebulized route was chosen.
Okay.
Thank you, sir.
Good evening, sir. I am Dr. Akash from Bokaro General Hospital. Sir, in the exclusion criteria, you have put the patients where intubation time was more than 30 seconds. I could not get, why did those patients were put in the exclusion criteria?
Very good. Thank you. The thing was that the higher the time of laryngoscopy, the more the stress response. So, we wanted to measure it for ideal laryngoscopy time. Only in difficult intubation, it is that you take much more time. The more you provide, it can be, the higher the intubation time or the laryngoscopy time, it can be causing the trauma to the airway also. So we wanted to restrict that. That could be other factor that could be causing other complications also. So all those patients in whom intubation time was more than 30 minutes, the findings that couldn't be generalized for the general population. That's why we excluded it.
Thank you. Thank you.
Okay, thank you. Thank you for the nice discussion.
Thank you so much, sir. Now I would call the fourth speaker of the day for short PG paper. The topic will be prevalence of vitamin B12 deficiency in the patients with ischemic stroke admitted in the Burnpur Hospital, a cross-sectional study. Please put your hands together for Dr. Ram Chandrajit Chauhan, ISCO Burnpur Hospital.
Good evening, respected chairman, judges and delegates. Myself, Dr. Ram Chandrajit Chauhan, consultant critical care medicine, Cell Hospital, Burnpur. Today my topic of presentation is prevalence of vitamin B12 deficiency in patients with ischemic stroke admitted in Burnpur Hospital, a cross-sectional study. Ischemic stroke continues to be a major cause of mortality and disability in India as well as the world. Nutritional deficiencies, especially of vitamin B12, is a significant and reversible risk factor. Vitamin B12 plays a vital role in neuronal function and DNA synthesis, and its deficiency leads to elevated homocysteine, promoting endothelial dysfunction, atherothrombosis, leading to ischemic events. The aim of my study was to determine the prevalence of vitamin B12 deficiency in ischemic stroke patients and its relationship with stroke severity. It was a hospital-based cross-sectional study conducted in the Department of Medicine, Burnpur Hospital from January 2025 to October 2025. Prior ethical clearance and informed consent were obtained, and 50 new onset ischemic stroke patients were included in the study. The inclusion criteria were radiologically confirmed ischemic stroke patients aged 18 years and above with onset of symptoms within the last 72 hours were included in the study, whereas those with hemorrhagic stroke with ongoing current vitamin B12 supplementation with pernicious anemia and with CKG stage 4 and above, and more importantly, those who refused to give consent were excluded from the study. Data like demographic, clinical history, National Institute of Health stroke scale, radiological investigation like CT, MRI, and blood sample for B12 and homocysteine levels were collected within the first 24 hours of hospital admission. Serum vitamin B12 and homocysteine levels were measured via chemiluminescence assay. And for a statistical analysis, we used chi-square test and student t-test, and p-value less than 0.05 was considered significant. Now, out of 50 participants, 18 were of age less than 60 years and 32 were of age more than 60 years. 30 were male and 20 were females. Out of 50, 10 were vegetarians and 40 were non-vegetarians. The other risk factors like diabetes, hypertension and smoking and alcohol use were 20, 18, 15 respectively. This slide shows the distribution of those risk factors among the patient with ischemic, the vitamin B12 deficiency and with normal vitamin B12 levels. Now, this is the Venn diagram which shows the overlapping of those various risk factors among the study population. Now, when we measured the vitamin B12 levels, we found a staggering 70%, that is 35 out of 50 patients were having vitamin B12 deficiency, as compared to only 15, that is 30% were having normal vitamin B12 levels. Similarly, the mean homocysteine level were higher in patients with vitamin B12 deficiency as compared to those with normal vitamin B12 levels, that is 18.4 versus 10.2. And it was statistically significant. More importantly, the mean NIHS scale, that is stroke severity, was significantly higher, that is 12.6 in the patient with vitamin B12 deficiency as compared to 9.1 in the normal individuals. And it was statistically significant. So the key findings were 70% had vitamin B12 deficiency, the patient with vitamin B12 deficiency had higher homocysteine levels as well as had higher stroke severity. The study demonstrated a high prevalence of vitamin B12 deficiency among ischemic stroke patients, which aligns with prior studies conducted in India. The significant associations were with age more than 60 years, which suggest cumulative nutritional deficits and impaired absorption with aging might be contributing to the deficiency. Vegetarian diet were mainly plant-based diet like adequate cobalamin, and diabetes mellitus, which may contribute through metformin-induced malabsorption. And the patient with vitamin B12 deficiency had higher homocysteine as well as stroke severity. Dubey Akash et al. Conducted a meta-analysis in India where he included 18,750 healthy participants, and he found that out of all those participants, around 51% had deficient vitamin B12 levels. These are some studies which aligns with my findings. So to conclude, This study shows a high prevalence of vitamin B12 deficiency among ischemic stroke patients in Burnpur Hospital, despite the dietary habit being primarily non-vegetarian. The significant associations were with increased age, vegetarian diet, and diabetes. The stroke severity was higher in B12 deficient patients. So my recommendations are: mandatory B12 testing in ischemic stroke workup can be introduced, implementation of community awareness on B12 rich diet, initiating B12 supplementation protocols for high-risk groups, and monitoring of B12 in diabetic patients, especially those who are on long-term metformin therapy. By doing so, we may be able to reduce the ischemic stroke-related mortality and disability, and also we may be able to reduce the care of ischemic stroke-related disables on the healthcare setting as well as the society. Since my study comprised small number of subjects, so we may need to conduct a large multi-center studies to validate the findings, and we may need to compare these findings with matched healthy volunteers. These are my references. My acknowledgement. Thank you, everyone.
So a very simple and important study for a common disease. How does we can correlate it with it? So can we have any questions from the audience?
Dr. Chauhan, I think it's a very nice prospective study that you've done, because getting to know the levels, even you have measured the homocysteine levels. Now, this is a known fact. I think this is well understood and well accepted that vitamin B12's levels, homocysteine and stroke, the causal correlation is very high. So you've done this study good, you have taken all the effort with proper analysis, but what is different that you found in this study? So you talked about screening. I think the quality metrics of stroke then need to come into play, right? That is what is also that you would have included in your study one. And the second part is anything different that comes. You have compared with the other studies, but that is all known, accepted.
Yes, sir.
How would you put your study differently from the other references?
So in other studies, what we found, so that the number of vegetarians were significantly higher. As, like around some studies show 20, 30, some in like Western India, some studies found that 50-60% were vegetarians. But in our case, around only 10 out of 50, that is 20% were vegetarians, rest 80% were non-vegetarians. Still, we had found that the vitamin B12 deficiency was really high.
Okay, so if you're getting a different kind of prevalence or incidence, I think then it should be spread. Maybe for this area, we should get to know how it is different, right?
So whether it was a mere association or it has a causative role. Because vitamin B12 is, in time immemorially we know, it causes combined degeneration of cord, and it is a predisposing factor for peripheral neuropathy. For stroke, whether the cause has been established or it is a mere association.
Sir, since this was a cross-sectional study, just an observational study, so our aim was to identify the association. Since we know indirectly that vitamin B12 deficiency causes hyperhomocysteemia, which causes endothelial dysfunction, and atherothrombosis that causes stroke.
So it is an hypothesis, na? It is hypothesis, whether it has been proved or not.
Sir,
it is in hypothesis. It causes hyperhomocysteemia and that it can cause stroke. Whether the cause has been established or not.
Sir, we didn't establish in our theory, sir. We just established the association.
Yes, that's I wanted to highlight, sir. Thank you.
Okay, thank you. Thank you for nice listening.
Thank you so much, sir. Coming on the fifth session of the day is with the topic of prediction of preeclampsia using first trimester uterine artery Doppler and pregnancy associated plasma protein A by Dr. Shama Parveen from Bokaro Steel Plant. Hello.
Good evening, respected chairperson, judges, and delegates. I am here to present my study on prediction of preeclampsia using first trimester uterine artery Doppler and pregnancy-associated plasma protein A. As we all know, preeclampsia still remains the leading cause of maternal and perinatal morbidity and mortality worldwide, amounting to approximately 14% of maternal death globally and approximately 30% in India. Hence, prediction of the disease is very crucial. Although exact etiology of preeclampsia is still unknown, but primarily it is because of abnormal trophoblastic invasion into the myometrial portion of the spiral artery, leading to increased resistance within the uteroplacental unit, which can cause placental hypoperfusion, which can be detected by elevated pulsatility index in the uterine artery Doppler waveform. The other pathology is because of the placental dysfunction. Normally during placental development, there is a release of certain placental products into the maternal serum. One such product is PAPA, which regulates the insulin-like growth factor. Hence, if the level of PAPA is low, the level of insulin-like growth factor will be low, and that will impair the trophoblastic invasion and placentation, which can contribute to the development of preeclampsia and fetal growth restriction. Keeping these in mind, we aim to study whether the first trimester uterine artery Doppler and serum PAPA can predict preeclampsia with the objective of early prediction of preeclampsia by using these markers in first trimester and to find out their correlation with the development of preeclampsia. It was a prospective observational study conducted in the Department of Obstetrics and Gynecology over a period of 18 months after taking approval from Institutional Ethical Committee. We included 150 subjects for the study after applying inclusion and exclusion criteria. We included those patients who visited our ANC OPD with a singleton pregnancy in first trimester at or before 11 to 13 plus 6 weeks of gestation and willing to participate and to come for follow-up. We excluded high-risk pregnancies like multiple gestation, known abnormality in the fetus, obesity, pre-existing medical disorders, and not willing to participate in the study. After taking approval and informed consent from the patient, a detailed history examination was done at first visit, baseline demographics were noted. After confirmation of the gestational age and fetal cardiac activity, all patients underwent uterine artery Doppler examination along with routine anti-NBA scan and double marker test at 11 to 13 plus 6 weeks of gestation as a routine aneuploidy screening. Out of this, PAPA in multiple of median and uterine PI were noted. Patients were followed up till delivery. We assessed the outcome in the form of incidence and onset of preeclampsia, the value of uterine PI and PAPA, their correlation with the preeclampsia, as well as the perinatal outcome. Appropriate statistical tools were applied to analyze the data. Moving on to the results. Out of 150 singleton pregnancies who were assessed in first trimester, majority were primigravida with a mean age of approximately 27 years, belonging to lower or low middle class, had normal BMI, and we found no significant association between baseline demographics and preeclampsia. The incidence of preeclampsia in our study was 10.7%. When I compared the mean uterine PI and PAPA between these two groups, preeclamptic and normotensive group, we can see that the mean uterine PI was significantly higher, whereas PAPA value was significantly lower in preeclamptic patient as compared to normotensive patient. To assess the accuracy of the test, we plotted an ROC curve, and according to this, area under the curve for uterine PI was 0.884, which means uterine PI has a good discriminatory power to distinguish between preeclamptic and normotensive patient at a cutoff value of more than or equal to 1.34. And as a screening tool, it had a good sensitivity with a high specificity and negative predictive value. As per the ROC curve of PAPA, area under the curve was 0.778, which means it has an acceptable power to predict preeclampsia at a cutoff value of less than or equal to 0.8. And as a screening tool, its performance is slightly less as compared to uterine PI. But when we combine PAPA with the uterine PI, the sensitivity and negative predictive value improved further. Thus, we can say that combined screening showed a better detection rate as compared to either of the parameters alone. This is a table depicting the combined screening and the incidence of preeclampsia. We can see that those patients who had both the parameters or either of the parameters abnormal in first trimester, the incidence of preeclampsia in later part of the pregnancy was significantly higher as compared to those who had both the parameters normal. This is a neonatal outcome. Preeclampsia was significantly associated with adverse neonatal outcome in the form of fetal growth restriction, low birth weight, birth asphyxia, and early delivery. Thus, preeclampsia not only affects the maternal health, but it also significantly increases the neonatal morbidity. When my study was compared with other similar Indian international studies, my results were consistent with their finding, which showed that there is a significantly high uterine PI and low PAPA in those patients who later develop preeclampsia. Although there is a slight variation in the cutoff value, but overall the result supports the use of combined screening for early prediction of preeclampsia. Thus, to conclude, combined first trimester uterine artery Doppler and PAPA can be effectively used for early prediction of preeclampsia without any additional financial burden to the patient. Early identification of high-risk cases and start of preventive therapy based on these screening tests and close antenatal fetal surveillance will definitely improve the maternal and fetal outcome. However, further large and multi-centric studies are recommended to validate this finding and enhance screening accuracy. These were my references. Thank you.
We can have 2 questions.
Hello, so I'm Dr. Anisha from Jamshedpur.
Yes, ma'am.
I would like to just ask that use of uterine artery Doppler and PAPA has been used for last 10 years.
Yes, ma'am.
We all know it is there in the screening guidelines, and very large cohort multicentric studies have already been established the
Yes,
fact
ma'am.
that
Yes.
is used for screening tool.
Yes,
So
ma'am.
why not use the newer markers like placental growth factor in your study, and why did you choose these 2 parameters which we already know are useful? Number 1, and second is, what did you do once you get to know in first trimester that the patient is at high risk?
Ma'am, because of the cost trends, the other factor like PLGF and other screening markers, these are costly and patients are not affording. That's why in a low resource setting like us, we are using, and still the studies have not been done in our center. That's why we did it.
Yeah, but
and for
all over the world it is quite established.
ma'am, but in India still there is no universal protocol that you have to universalize
yeah, it is in
this
guidelines.
test.
It is recommended that it should not be used. Clearly, if you see the ACOG, the FIGO, the fetal medicine guidelines.
But
they
ma'am,
all
Aspirate
say-
trial, recently FIGO has done the Aspirate trial and they are recommending the combined screening, and based
not
on this.
coming the guidelines. No, you have to FIGO, placental growth factor, FIGO.
Ma'am, because of the cost trend,
Yeah,
the
that's
patient is not affording that. That's why we are planning to do that study, and maybe in coming years we will present. For the second question, ma'am, if the patient comes out to be high risk, we will start the low dose aspirin in the form of 75 to 150 milligram, and we will do close antenatal surveillance for those patients as considering a high risk patient.
Okay, thank you.
Thank you, ma'am. Thank you so much.
Thank you so much, ma'am. Thank you, audience, for the patience. Now coming on the second last session of the day, and the topic for the session is clinico-ecological spectrum and high-dose steroid response in West syndrome, an experience from a tertiary care center in eastern India by Dr. Shikha Swaroop from Tata Steel Plant.
Respected chairperson, judges, and ladies and gentlemen, good evening. Infantile epileptic spasm syndrome, or commonly known as West syndrome, is a serious epileptic disorder affecting young infants. It was first described in 19th century by W.J. West in his own son and is commonly known as Salam seizures. It is a rare disorder with low incidence, and it is a triad of infantile spasm, e.g. showing hips arrhythmia, and developmental regression or arrest. These spasms are often confused for startle reflex or colic abdominal pain and is missed. Traditionally, first-line treatment is adrenocorticotropic hormone, and in recent years, high-dose prednisolone has emerged as an alternative therapy because of comparable efficacy and it is inexpensive, readily available oral medication. Still, treatment of spasm is being delayed because of lack of experience and knowledge. The research gap identified was a scarcity of data from Indian subcontinent where first line as high-dose steroid was used for treating these spasms. Keeping this background, a study was planned with aims and objective to determine clinical and etiological profile of children with West syndrome and to determine the treatment outcome of infantile spasm at 14 days, 3 months and 6 months post high-dose oral steroid. It was a prospective observational study. Data collection was done over 5 years at our center. Age 2 months to 2 years, West syndrome patients who were diagnosed at our center and received first-line treatment and were followed up for minimum of 6 months were included. Patients who were lost to follow-up within 6 months in whom first-line treatment was received elsewhere or cases of tuberous sclerosis were excluded because first-line in them is vigabatrin. Patient came to us in OPD and IPD, diagnosis of West syndrome was confirmed and then they were subjected to screening for tuberculosis. After the screening came negative, they were started on high-dose prednisolone and response was assessed at day 14. Either there was no response, partial response or complete clinical cessation of spasm, that is clinical response. This patient underwent repeat EEG and if on EEG hypsarrhythmia was absent, they were labeled as cases of remission and they were followed to look for recurrence of spasm. All other patients were started on second line vigabatrin and followed. A structured proforma was used to collect data. 45 cases of West syndrome reported to us, 7 were excluded, 5 we lost to follow-up, and 33 cases were analyzed. Appropriate statistical analysis was done. Fisher exact test was applied to determine association between categorical variables. We found that males and females were almost equally affected. Most of the patients presented between age 6 to 12 months, mean age of presentation being 7.2 months. Term gestation was predominant with 76% and perinatal asphyxia was present in 33% of cases. Head circumference was normal in 55%, followed by macrocephaly in 39%. Muscle tone was normal in 58%, followed by spasticity in 30%. Patient at the time of presentation had developmental delay in 85% of cases. Infantile spasm at the time of presentation occurred in cluster of 4 to 5 and flexor spasm was most common. Abnormal MRI was detected in 18 patients and most common abnormal MRI changes were hypoxic ischemic injury followed by neonatal hypoglycemic brain injuries and cortical malformation. Genetic test was offered to those where clear etiology could not be established after basic workup. We found 11 abnormal genes and most common were CDKL5 and CARS1 mutations. Etiology could be found in 78% of cases and most common etiology was genetic followed by perinatal asphyxia and then neonatal hypoglycemic brain injuries. Response as day 14 was assessed and we found that 76% of cases has complete cessation of spasm. Out of these, 2/3 of babies also had electrographic remission. We found that normal MRI was significantly associated with early electrographic remission. These patients were followed and at the end of 6 months, we saw that recurrence in these electrographic remission cases was 23% and it is heartening to say that 76% of these patients remained spasm-free. Side effect profile was minimal with no side effect in 9 patients and only 1 patient required hospitalization for infection. So in our patient cohort, high-dose steroid was well tolerated. Compared to other studies, response in our study was similar with recent study done in India in 2025 and in China. Etiology, the most common was genetic in our study compared to other where it was birth asphyxia. Limitation were small sample size, single center study, and long-term follow-up was not done. So to conclude, genetic factor was the leading cause in our study. Our study proved high clinical efficacy of high-dose prednisolone, and it was well tolerated in our patient cohort. Thank you.
Good. Hello, good evening, ma'am. I'm Dr. Nilesh from JLNHRC, Billai. Ma'am, you gave prednisolone high dose to infants for the West syndrome, but that is also a established fact that gold standard is ACTH. Then the first line is same dose you used of prednisolone, and then if it is a tuberous sclerosis, then you add that gabapentin. It's the same thing. How is it different?
No, see, historically ACTH is gold standard, but now there are recent randomized controlled trials which are saying that previously we used low dose steroid, and in recent 5 to 6 years we are using high dose steroid. And in many of the large randomized controlled trials done in UK and US, they have found that its efficacy is almost equal. And we all know that ACTH has to be given intramuscular, it is costly, and compliance is poor. And early we treat this spasm, the better is the spasm control and neurological outcome in the future. And prednisolone is very easy to administer. So this paper is for sharing our experience with high dose steroid.
So, ma'am, actually the thing is that you use the same dose that has been recommended for treating the West syndrome. So can I take away the home message that you were already establishing the fact that has been established that
No,
this
we are
supporting document, you are providing the supporting
yes,
document for that dose only.
That in our patient cohort, in Indian subcontinent, it has not been, there is not many literature. So in our patient cohort also, it is well tolerated.
Okay, thank you.
How high is high? Sir, maximum we can go till 60 milligram per day in young children. It is 4 to 6 milligram, but maximum we can milligram per kg per day, but maximum we can give 60 milligram in a day.
Thank you so much, ma'am. Now, finally coming on the last speaker of the day is Dr. Sumit Mukherjee, Durgapur Steel Plant, and the topic of Sir would be caregiver burden and its correlation with the severity of dementia among the caregivers of dementia patients in an industrial hospital.
Where is the timer? Should I start? Very good evening to the respected judges, delegates and dignitaries. My research work is related with the caregiver, not directly with the patient. The topic is caregiver burden and its correlation with the severity of dementia among the caregivers of the dementia patient in an industrial hospital. India is one of the most populated countries in right now. Increased life expectancy and access to quality health care has led to increase in the geriatric population. Geriatric population is expected to be around 20% of the country's total population by the year 2050. Dementia is one of the most devastating neurocognitive disorder. Caregiving of such kind of patient has a consequence of tremendous adverse impact of on the caregivers of physical and mental health. Now, what are the rationale of the study? Caregiver stress often underestimated in our clinical setup, important for early identification and intervention. Industrial hospital setup provide unique workload challenges. Regarding objectives, to assess the caregiver burden, to assess the severity of dementia, and to make a correlation between severity of dementia and the caregiver burden. Also, to describe the socio-demographic profile of both the patient and the caregivers. Regarding methodology, the study was conducted at Department of Psychiatry of DSP Main Hospital with 40 primary caregivers of diagnosed dementia patient according to ICD-10. The study duration was 2 months and it was a cross-sectional observational study and convenience sampling technique was being used. Regarding inclusion criteria, caregivers who are aged more than equal to 18 years and who are involved in the caregiving process for more than 6 months were included in the study, but paid or institutional caregivers and caregivers with known cognitive impairment, substance abuse, known psychiatric disorders were excluded from the study. Regarding the stages of the study, first, we obtained consent and registration of socio-demographic data for both the patient and caregivers were done. Later on, the Zerith Burden interview scale was being used for assessment of the total burden score. Later on, dementia severity rating scale was used for assessing the severity. Lastly, the data analysis. Now, brief description about the Zerith Burden interview scale. It's a 22-item scale, encompasses mostly 3 domains: physical, emotional, and social domain, with a score range of 0 to 88. If the score is within 20, we denote it as a little or no burden. If the score is more than 60, we denote it as a severe burden. Dementia severity rating scale encompasses 3 domains: cognitive, functional, and social domain of the patient, and the score range is 0 to 54. If the score is within 18, we denote it as a mild dementia. If the score is more than equal to 37, we denote the case as a severe dementia. Now coming to the result. In this study, 45% of the patient were in the age group of 70 to 79 years and 30% of the patient were having the age of more than equal to 80 years. Predominantly the cases were male, that is 65%. Regarding socio-demographic data of the caregivers, 60% of the caregivers were in the age group of 40 to 59 and 20% of the caregivers are themselves above 60 years of age. Predominantly caregivers were the females, that is 65%, and most importantly 85% of the total caregivers are the direct family members of the patient, that is either son, daughter or spouse of the patient. Now the first bar diagram shows in this study 45% of the patient were having moderate to severity level of dementia, and the second bar diagram shows 40% of the caregivers complains of mild to moderate burden, whereas 35% of the caregivers complains moderate to severe burden. The box plot diagram shows gradual increase in the median value of the total burden score according to the dementia severity, and the scatter plot diagram with R value of 0.62 shows positive correlation between the caregiver burden and dementia severity. Now coming to the discussion part, 35% of the caregivers experience moderate to severe burden in this study. Moderate dementia cases form the largest group, typical OPD finding in our country. Employees who were deployed in work area was expected to have more severe cognitive impairment in compared to those who worked in the non-work area, but no statistical significance was established for this study. Positive correlation indicate that caregiver burden increases with dementia severity. This aligns with earlier research. Severe dementia patients require more physical support in maintaining activities of daily living. Caregivers of severe dementia patients experience emotional, financial and social strain simultaneously. What are the limitations? Single center study, small sample size limits generalizability. There are chances of reporting bias. DSRS scale may not capture subtle cognitive fluctuations, and lack of longitudinal follow-up may restrict understanding of the burden progression. Now what we can do for betterment of the situation? Routine caregiver burden screening program and caregiver education program at OPD level, hospital-based support groups and counseling session to make them more resilient and to obtain more coping skill, and using of certain apps like Samarth, etc. Increase availability of respite care service and policy level support. To conclude, this study demonstrates significant association between dementia severity and caregiver burden. Improving caregiver support will ultimately help in caregiver well-being. Overall, the government should make some policy decision and structure intervention and policy level reforms at national level. These are the few references. Thank you very much for present hearing.
Good evening. That was a very detailed presentation. Thanks for that. I just had a few queries on your selection, this thing. What was your sampling method you said?
It's a convenient sampling technique.
Right. So that is a very, and you had a questionnaire, so it is a relevant selection process. But the convenience sampling is usually used because it makes it fast, it's easier to do, and you can get quick results.
Exactly, sir.
But a very big negative of that is a bias.
Chances of bias.
Which comes in. Not just answer bias which comes in. You followed up your slide with a very detailed inclusion and exclusion criteria. I have a feeling that only increases the bias. So when you come towards the end of your presentation, you're just saying the same thing, that okay, if my family member is more ill, I will have more burden. And somewhere in that, in the beginning, if you had not kept a inclusion-exclusion criteria, any person with dementia coming in, and you give them the questionnaire, and you do maybe it would have had more. So do you have any?
Regarding dementia research, there is a 1066 research group formulated by King's College of London. They have the opinion that only less than 10% of research has been conducted in those countries where more than 66% of dementia patient resides. That is in our country, in developing country, there is very bare minimum research regarding dementia.
No, I was just wanting to know, is that when you put in such stringent inclusion and exclusion criteria, are you in some way increasing the bias in your study? You are already doing convenience sampling, and then you are also putting in such a strict inclusion exclusion. So that was my question.
No, sir. Actually, if I include paid or institutional caregiver, that is, those are known as formal caregivers, there is a possibility they will not report the symptoms properly.
Right, thank you.
And also, if I include known psychiatric cases of known psychiatric disorders and individuals who are having themselves cognitive impairment or all sort of things, then there is a possibility of not getting adequate result in the questionnaire.
Okay, I think last question, Dr. Acharji. No. Achha. Okay, then thank you, Dr. Mukherjee, for your presentation.
Thank you so much, sir. This was an amazing short PG paper presentations by everyone. I would like now to call upon Dr. Vinita Dwivedi ma'am to felicitate Dr. Bibi sir and Dr. Vinita ma'am. Dr. Vinita felicitating Dr. Vinita. Please clap, everyone. Dr. Bibi Karuna Mehsa. Thank you so much, everyone, for your presence. Now this concludes with day 1 of the program. And for today's program, now I would like to call the organizing secretary, Dr. Rajiv Kumar sir, to conclude the session. Thank you so much.
Good evening, sir. Actually, the tiring session of day 1 program is now over, and there is a plan for from the organizing team to take you people to one of the best sites in Durgapur, the heritage nominations is done there. It is Shiv Shakti Dham temple in Andal. So the bus is there outside. One who are interested for visiting the temple, please ride over on the white bus. And those who are not interested, please catch red bus that will carry you to your respective staying venues. White bus is for Andal temple visit, and red bus will carry you to your staying station at City and Peerless. So please go outside, and as per your preference, you take the buses. We will again rejoin tomorrow's session at 9 a.m. and from 8 a.m. the breakfast will be ready here. Thank you so much. There is a gala dinner today at Peerless Hotel from 7:30 onwards, means 8 p.m. onwards. So you all are invited, and then the invitation letter is already being given to you. In the Peerless Hotel, the gala dinner is planned.